everyone, and
Good
we,
evening, everyone.
we are on today, Friday evening, Friday dressing, and today's Friday dressing is Phakic IOLs. Welcome to our scientific committee session on Phakic IOLs. I'll just start my screen share and introduce to you our very eminent chairpersons, panelists, moderators for today. So it is Phakic IOL, learn it from the masters case files. And I must thank first and foremost Dr. Amit Porwal, Dr. Fairuz, Dr. Jatinder Singh Balla, Dr. Krishna Prasad Kudlu, Dr. Parikshit Gopte, Dr. Som Shila, and Dr. Sonu Goel for all the hard work of all these webinars. They constantly keep up the hard work, and this is the result. Wonderful webinars. Our chairperson today, Dr. Mahipal Sasdev, President AIOS, Chairman Scientific Committee IRSI, and Chairman and Managing Director, Center for Sight Group of Eye Hospitals. Welcome, sir. Our next chairperson, Professor Jeevan Singh Tatyal, Professor and Head of Cornea, Cataract and Refractive Surgery Services, RP Center for Ophthalmic Sciences, AIMS, New Delhi. Sir, a very, very warm welcome to you. Dr. D. Ramamurthy, Founder Chairman of the Eye Foundation and our past President, AIOS. Sir, welcome. We have with us an expert panel of people who do a huge number of Phakic IOLs, and it is these masters who are going to be the brightest stars of today. Dr. Suhas Haldipurkar, founder of Lakshmi Eye Hospital, Lakshmi Eye Institute, and Lakshmi Charitable Trust. Dr. Sudhan Bharti sir, Director of Bharti Eye Foundation, New Delhi, and Bharti Eye Hospital, New Delhi. Dr. Purendra Bhasin, Director, Ratan Jyoti Netralaya, Gwalior. Dr. Namrata Sharma, Secretary, AIOS, Professor of Ophthalmology, Cataract, Cornea, and Refractive Services, AIMS, New Delhi. Dr. Parimal Desai, Director and Chief Surgeon of Ashirwad Children and Eye Hospital, Maninagar Cure Site Laser Center, Ahmedabad. Dr. Sanjay Chaudhary, Chairman and Managing Director, I7 Group Eye Hospitals, New Delhi. And to welcome our superstars who are going to be our presenters, our moderators, and our team of scientific committee will do the needful. I now request Dr. Mahipal sir, and then Dr. Tatyal sir, and then Dr. Ramurthy sir to welcome our audience and our viewers, and a warm welcome from you, all of you, would be something that we would look forward to, sir.
Thank you very much, Dr. Partha, and thank you very much, Team Scientific Committee, for organizing this webinar. I think over the years since the ICL came into vogue, I still remember the first ICL that I did was in the previous century, 1997 or 98. That's the first ICL that I did. That was the V1 model. Ever since, I think it has really gone several notches up. And Dr. Partha, I think he's one of the great proponents of the ICL. I remember having done courses with him every year, year after year, which was a very famous course that he used to run in the AIOS and outside. While Dr. Partha is still doing the courses, he has graduated me to be the chairperson now and not a speaker anymore. So Partha, I am aging, but your hair are jet black. And all that I wish to say is that the speakers who are here are really very eminent, and they have lots and lots of experience. Today, I think there are very few, if at all, any ifs and buts of regarding the Phakic ICLs. There are 3 companies in India which are also manufacturing the same, and the toric variety is giving good outcomes, as also the other varieties which are there. So I think the Phakic IOL or the ICL market has grown significantly across the world, and it is at places where people do not have access to an excimer laser or a femto or a smile, etc. They might be doing it even for any power of correction of refractive errors. But obviously, there are the cases where we cannot fit in, which is the laser vision correction or the smile, and that under those circumstances, we would be doing and offering maybe thin corneas or cross-linked corneas and those kind of things, the ICL. So I think all of us, all ophthalmologists need to know about this technology, because this is a technology which does not need any increased instrumentation, and a normal ophthalmologist who has a normal cataract surgery setup can do that. So great, Partha. I think your scientific committee and you are doing a great job. And this is something in the armamentarium of all cataract surgeons, all refractive surgeons, that the people should know as to how to do it properly. Because if done improperly, it can cause problems. But if you do it properly, you can get excellent results, and the visual outcomes are fantastic. So I think without much ado, I welcome all the delegates, and I wish to thank the scientific committee for having chosen this topic. So over to all of you, and we hope it's an interesting session, because I think there are a lot of video presentations, and the speakers and the panelists are really uh, great surgeons who have a lot of experience in this technology. Thank you, Partha.
Thank you, sir. Tityal, sir?
Yeah, good evening, friends. Indeed, it's the experts which are there from the entire country, which are going to share the experiences of phakic IOLs. And I share the same views which Professor Mahipal had just talked about. I think what the beauty of phakic IOLs is now in a posterior chamber, and the fear of having a cataract, glaucoma complication has totally gone off the mind of surgeons. And the patient satisfaction is one of the best thing which has come out in last decade or so. The quality of vision after phakic IOLs would be the best amongst all the refractive procedure which is being done, let it be in cornea or anywhere, or a clear lens extraction in that way. So I consider this is the future of refractive surgery in terms of a correction of myopia or a hypermetropia or a high cylinders, or in a difficult situations, these lenses are handy. And now people are graduating to a moderate to low degree of refractive errors. That's the advantage of these phakic IOLs, newer generation phakic IOLs. And most importantly, I think it is one of the safest refractive gadget we have for our pediatric cases. I think that we need to assess also, because of a reversibility of this procedure, which is going to be a safer in a pediatric patients also. So I consider people have to know about these phakic IOLs. We know that things have improved so much in last decade or so in terms of sizing of these lenses, and we know the long-term results of these lenses. And I understand the entire fraternity of us have knowledge on phakic IOLs now, and this today's webinar will definitely have more clarity on the basic aspects of phakic IOLs and how to manage complications, which is, I think, nobody talks about in many places. And complication management, what we can, as an expert, give it to a general masses, would be the best thing in this webinar. So I again have the same sentiments. Congratulations to AIOS, especially today the scientific committee headed by Partho. I wish you all the best.
Thank you very much, sir. Sir, a word from you, Dr. Ramurthy, sir.
Thank you so much, Partha, and the entire scientific committee for this very kind invitation. I think it's a timely topic. I've had the privilege of being part of your AWS courses for such a long time, always been a super hit. And I think gone are the days when refractive surgery used to be a single procedure specialty, just PRK or LASIK or femtolasic. Today we have a gamut of procedures, and both surgeons and patients have the freedom of choice to pick and choose what is exactly suitable to them. And as was said by my two preceding speakers, the indications for these lenses is increasing. And any good anterior segment surgeon is capable of taking it on without really a significant addition to the armamentarium they require. Obviously, any procedure doesn't come without complications. And a good look at that is also important. I think we have a stellar panel here, and we look forward to a very educative evening. And at the end of the day, maybe there would be a lot more converts taking on to phakic intraocular lenses. Now that options are available, which are also cost effective. So I think if you are a full refractive surgeon, phakic IOL should be a part of your armamentarium. And maybe this webinar will go a long way in achieving that. Congratulations, kudos to the entire scientific committee.
Thank you very much, sir. Thanks a lot. And now over to our three moderators for the session, and Dr. Krishna Prasad Kudlu, Dr. Sonu Goel, and Dr. Som Sheila. So
I also welcomed Dr. Namrata Sharma. She just joined our secretary AOS. Also, I welcome Dr. Gaurav Lutra also who joined us. Over to Som Sheila.
Thank you very much. It's our great pleasure, as the chairpersons already described, that we have such a vast amount of experience. I don't know, years and years of experience, if you count all the panelists, the chairpersons, and our scientific committee chair, as well as all the speakers. So let us start off with the first presentation. And the first speaker will be introduced by my colleague and friend, Dr. Feroz. Feroz, you ready?
Yes. Hi, Dr. Som Sheila, and good evening to everyone. I'm going to share the slide. I hope the slide is visible and I'm audible.
Yes, to both.
So it's my pleasure to introduce Dr. Anantha D, who is the ICL opening batsman today. He's a very young, dynamic phaco-refractive surgeon from Lotus Eye Hospital and Institute, Coimbatore, and he's also the assistant medical director of this prestigious organization. After completing his residency from Command Hospital, Bangalore, he went ahead doing his phaco-refractive training at Lotus Eye Hospital itself under Dr. S.K. Sundarmurthy, who is very renowned and famous in the field of ophthalmology and very illustrious in training a lot of best phaco-refractive surgeons in the country. So I would like to highlight that Dr. Anand D has been extremely dynamic, and there is a list of awards that he has won. And one of them is the Young Achiever Award in the Eye Beach Festival just last year, where Dr. Kudlu had organized. Congratulations. And the cherry on top is the ICL 500 Award at Malmö, Sweden, that Dr. Anandi had bestowed upon. And as I would take you through, he has done over 25,000 corneal-based refractive procedures. And as far as ICL is concerned, he has done over 1,500 ICL implantations so far. And we couldn't think of anyone better as a speaker taking us through the topic of ICL today. Welcome, Dr. Anandi, and we are looking forward to master strokes from you, 6s and 4s in the topic today. Over to you. Good evening, everyone, once again.
Thank you for those words, Dr. Feroz. Shall I share my screen?
Yes, please.
The screen visible?
Yes, it is visible.
So, Sarve Jana Sukhino Bhavantu. Let us all stay safe during Corona time. First of all,
Sometimes the which button, sometimes you can forward it from the pad, mouse pad, or.
so first of all, my heartfelt thanks to Partha sir and his team for considering me to deliver this basic talk on Phakic IOL. So, no financial disclosures. I'm just a high volume ICL surgeon, and I love this material, Colamber. I always feel this is the material which has led to the success of this ICL globally. So, success of any refractive procedures, I always think it is dependent upon two factors. How good a doctor is better in counseling or convincing a patient for refractive procedure, and how good he is at managing the complication, if at all, if it happens, even though it's rare in refractive surgery, because all refractive procedures are very simple and easy to master. So over the next 4 or 5 minutes, I'll be discussing in a very simple way how I go about and work up a case of ICL. I always offer ICL to LASIK reject patients, maybe because of inadequate tissue, thin corneas, bigger pupils, a patient who is suffering from moderate to severe dry eye, if there is any family history of keratoconus or ectasia in the family, and for all keratoconus patients who have been stabilized with C3R, 6 months later I advise it, but I will not advise if the keratometric value is more than 58 and if they have descended cones. And I also offer, since we are known as a refractive center, majority of the patients do refer ICL patients. And for these subset of patients, I offer it as a primary procedure. There are some patients who ask for a reversible procedure, who are very worried about the complications. I offer it as a primary procedure and to all patients who have got higher degrees of refractive errors. And whenever I'm speaking to them, I always tell them that ICL avoids all the complications which are associated with corneal-based procedures, such could be flap-related complications, can be regression or ectasia. And I always tell them that ICL never induces dry eye because I'm making incision of just 3 mm in a peripheral cornea. And for the patients who demand a good contrast, ICL even today remains the best refractive procedure. I always try to understand my patient by knowing their lifestyle, their realistic expectations from the procedure, their occupational demand, and I also pay attention to some of their decisions. They should not be some sort of patients who are just provoked by the ads which are given by the hospitals. They should have really realistic expectations. And whenever I sit for a counseling, I should make sure it is a family discussion. I make sure who is paying for the procedure and then explain regarding the monetary aspects also. I show them the video. I tell them that this is done with topical anesthesia, completely pain-free. The vision is recovered within 1 or 2 hours, and I just take less than 2 minutes to do the procedure, and it's done on an alternate day. This convinces the patient majority of the times, and I also tell them that if at all, if some complication happens, it is reversible. This convinces them more for the procedure. And as everyone knows, the patient criteria for refractive surgery remains the same. Patient should have completed 18 years, it should have a stable refraction, and the range of correction we can treat until -18, hyperopia until +7, and toric until ±4.5. And we need to pay special attention to past history of steroid response, past history of previous intraocular surgeries, and any evidence of uveitis in the past. Coming on to the examination, the basic examination includes uncorrected visual acuity, discorrected visual acuity. If any accommodating issues are suspected, cyclorefraction is mandatory. And on slit lamp examination, make sure that you rule out all the opacities or scar which is present in the cornea. Clear cornea is a must for ICL procedure because I don't want any qualitative disturbance post ICL surgery because of this scars. I always make sure each and every patient who is getting worked up for ICL will be seen by my glaucoma consultant to get the gonioscopy done. I make sure that the angles are open by grade 3 or grade 4 in all the patients. Otherwise, sometimes we assess using our new innovation technique also. To assess the anterior chamber depth, I still rely upon my OpScan. FDA tells that the minimum criteria for ICL is 3, but majority of the clinicians, we take the bottom line as 2.8. And we should make a note about the pupil also. Any pupil size 5.5, I prefer or defer to do ICL in those subset of patients. Once the patient gets dilated, we need to look for the lens clarity. Any evidence of early development of cataract becomes an absolute contraindication for ICL implantation. This has to be thoroughly evaluated for the CD ratio, notching any evidence of glaucoma signs. Do not miss out ocular hypertension, other glaucomas. And peripheral examination is very, very important because it's an intraocular procedure. RD later can be blamed for the ICL procedure, so retinal surgeon should thoroughly look in for the periphery. If at all, if he finds out any retinal degeneration, it has to be barraged at least 10 days prior to procedure. Intraocular pressure has to be documented. Tear film assessment is always important. Post-surgery, quantitative disturbance in the vision should not be blamed upon the ICL procedure. And for keratometry, I believe upon the topography. That is ideal. And any postural curvature changes which are evident on the op scan not to be really given importance, because the impact of that is very minimal on the ICL procedure. The most important and the deciding factor is white to white. This is very, very important. To measure the white to white, we have so many parameters: digital calipers, manual calipers, and op scan. Anti-segment OCT cannot measure the sulcus to sulcus. UBM with 35 megahertz can measure sulcus to sulcus in a single picture it gives us. And IOL master overestimates this thing. We should always remember that relative to limbus, sulcus to sulcus distance on an average is around 0.42 millimeter bigger than white to white. And in reality, always sulcus to sulcus diameter varies and undulates in its anatomy. And whenever I'm taking a measurement with an caliper, I make sure that the patient is in a lying down position. Especially on my examiner microscope, I get a good magnification, and I take the measurement from clear cornea to clear cornea. Once the AC depth white to white is available, the refractive details are passed on to the STAR surgicals. They have their own manufacturer's instruction, and based upon their vortex formula, they do provide ICLs. These myopic ICLs are available in 4 measurements: 11.6, 12.1, 12.6, and 13.2. And these days, EVO lenses have increased their optical diameter by 0.3 to 0.5 mm. For bigger pupils also, we can use these sort of lenses. And we should be always careful whenever the white to white comes between 11.6 to 11 and 12.3 to 12.4, we should be carefully measuring the white to white, because this decides the IOL size. Over sizing may bring about a shallow AC, and undersizing may bring about a cataract in this set of patients. So this is just regarding the details. I think the rest of the speakers will be speaking regarding the technique and the other complications associated with ICL. Thank you.
Dr. Somshila?
Yeah, thank you very much, Dr. Ananth. I think that was an excellent overview. What we'll do is that we'll take a couple of comments each from our panelists. So the panelists to discuss your talk, Ananth, will be Dr. Suhas Adipurkar and Dr. Parimal Desai. And we'll just quickly bring them in. And the plan is to finish up with the first 3 presentations. And then we're to come back for a more detailed discussion for the first and second talk. So Dr. Hadipurkar, I see you're ready. So if you can just give a quick comment regarding the first presentation.
Well, yeah, thank you, Somshila. Well, it's a nicely made out presentation. Some of the points he brought out are really important. But what I wish to just add is that it is not so important that you have to have a crystal clear cornea for an ICL. In fact, most of the cases where LASIK cannot be done, where there are few foreign body opacities, some even peripheral corneal scars, or post pterygium, all these patients are good enough for ICL, because what matters is the axial and periaxial cornea that's clear, and as long as everything else is good enough. With regards to indications, in fact, post cataract refractive surgery surprises. In fact, there it's a great boon. If you want to do a piggyback, if the patient has missed out on his multifocal vision, you always have these EDOF ICL that have come, which can be used as piggyback lenses. When it comes to detailed counseling, I am of the opinion that very often when we do a detailed examination, we see some corneal non-progressive lens opacities. It's not necessary to be worried about, because if the patient knows that he's going to get another 15 to 20 years of clear, good vision before the time comes for us to take out the lens, especially in elderly population, this ICL seems to really work well. When it comes to ocular detailed history, what I insist is that in a fully dilated pupil, the lens needs to be checked for its status, the zonulars, especially these are high myopic patients, their zonular status, and of course the peripheral retina will definitely have a look. Another last point that I wish to really bring in is with regards to the lens vaulting, the achieved vault. We do these white-to-white measurement, various different techniques. But what I feel is, if you are consistent with one technique and just do it with single hand with a proper protocol, that is enough, because all the research has come out to tell us that the achieved vault will depend up to 40% of the times, on only 40%, to the extent of 40% on all the biometric measurement that we do. And there are some unmeasurable points that are responsible, like compression of from the iris and dampening effect of the ciliary sulcus are also responsible for giving you the achieved vault. But the good part is there's a wide variation from almost 90 to 1000 micron of post-op vault with which a patient can comfortably stay, because we very often see in a low myo, patients do have shallow kind of the vault is very low, and but it doesn't really matter, because you can regularly every year check the patient and things really can work better. So I think because we shouldn't be so much worried about the post-op vault, especially with the newer lenses with the center port, that issue is of a less importance than in the earlier days.
Thank you very much. Dr. Desai, your comments to this? Please unmute your mic for us.
Parimal sir, you can unmute the mic, sir.
Hello. Am I audible?
Yes, carry on, sir. Just a brief comment, sir, because actually Dr. Gaurav Lutra will have to leave, so we just will take just brief comments.
Okay, I'll just finish it.
We will go on to the detailed discussion again.
Fine. The age group, which should not be, means at our place it is more than 20 plus. 18 is a progressive myopia thing. So we select the age group about more than 20. The other thing is we had a bad experience once when we did not measure the pupil diameter. So when we did not measure the pupil diameter, we had a patient complaining of severe glare because his pupil was very big, and we had to explant that thing there. The patient was the son of police officer. So one thing is there. The third thing is Suhas and Anand, both of them, they told that white-to-white measurement is very important, because that the whole outcome depends upon that thing. Otherwise, he has covered everything very well. Thank you.
Somshila, can I make one comment only?
Yes, sure, sir.
I think Anant has done a very good job in a pre-op assessment of these patients. If you have access to a newer generation OCT like KCR2, which will give you a very good measurements, apart from the good AC depth, it gives an angle-to-angle analysis and gives you actual angle measurements like a trabecular iris angle and the actual angle opening distance. They are two important parameters nowadays people take for deciding if patient is suitable or unsuitable. So I think good new generation OCT is part of assessment of ICL nowadays, or of Phakic IOLs.
I have to do more later.
So, Somshila, I think from the first talk, we should have a good take-home message that sizing is very, very important for the right wall to come up. And sir, I would just chip in to put in a question, just quick question about the lens rise. There is a lot of concept about the lens rise. I think 37% of cases still we have surprises in the vault. Tatyal sir, if you could, just quickly brief up.
Sir, we will take this discussion. This is a very important point that Sonu has brought up. But actually, let us take Dr. Gaurav Lutra, and then we'll come back to this very important discussion about the lens rise.
Thank you. So what we'll do is, we'll just switch gears slightly. And Dr. Kudlu, are you there? Are you ready? Yeah, Dr. Kudlu will take over to moderate the session for Dr. Gaurav Lutra.
Yeah, it's my pleasure to introduce my friend Gaurav Lutra, who is the director of Drishti Eye Institute. Also, he specialized in most of our eye surgery. You talk to him. His expertise in pediatric ophthalmology, expertise in keratoconus. I think he can do anything, most of the things in ophthalmology. Apart from his talent in the field of ophthalmology, he also have got some of the positions in our field of in our branch. Like he's a chairman for ARC, IRSI. He's also president for Dehradun Ophthalmological Society, chairman of award committee, Uttarakhand Ophthalmic Society. We put there together as a member scientific committee, All India Ophthalmological Society, and also he's a member managing committee, All India Ophthalmological Society. The man who has done probably the highest number, few of the highest number in ICL, none other than Dr. Gaurav. We are eager to hear from him, and he'll be talking about Phakic IOL implantation mishaps. Over to Gaurav.
Thanks a lot, Dr. Kudlu. I don't deserve all that, but I'm so grateful to be invited by the scientific committee of AIOS, Dr. Partha, and all the members. And I'm grateful for this opportunity. And I'll share my screen. Thanks, Dr. Kudlu, for accommodating me, Dr. Partha, Dr. Somashila. I apologize for breaking order here because I have to leave for another webinar, and I hate doing this. But I hope my screen is now visible. So. Okay. So, first of all, I would like to say that while Phakic IOLs, I've been doing them for almost 15 years now, and, they are amazing. They are very safe to do. So please don't go back with the message thinking that, lots of complications. But as they say, if a surgeon does surgery, he's bound to, if you drive a car on the road, you are bound to, scratch it somewhere. So it always helps to learn how not to scratch it. And it always helps to know how you can preempt complications. I hope I'm audible clearly, Partha.
Very good.
Thank you so much. Thank you. So I'll quickly run through 3-4 of the common mistakes that we might make, which I've learned myself the hard way over the years. And this is one of the first things which I learned. While we are all now trained to do wound-assisted injections through small incisions, we've been going smaller and smaller with the 2.2 millimeter incisions. However, with ICLs, it is very, very important not to attempt wound-assisted injections at all. Sometimes you are going through a cataract list and you suddenly have an ICL patient, and subconsciously you just go ahead with a wound-assisted injection. Now it's very important to have the right-sized incision. Many times your assistant will forget and give you the smaller blade, but we have separate blades in different sets for the ICL. It's best to use. I use a 2.8, but it's good to start with 3.5 and maybe subsequently graduate to 3 or 2.8. For me now, 2.8 works well. It's important to get the tip of the cartridge inside the inner lip of the wound. If you don't have that, your ICL may get stuck, or you may have an aborted injection and the ICL may open up outside. This is what can happen sometimes. And this shows another instance where, we were trying to inject the ICL. Of course, the loading is straightforward. Now, here again, we were trying to inject. Counter pressure with the left hand is very, very important, and making sure that sometimes if the patient moves under topical anesthesia, your tip may get disengaged from the incision. So you have to use counter pressure very nicely. So this was another very old video which I pulled out where the ICL got stuck and we were in a bit of a situation. And it's always tough because these ICLs are very thin. So, trying to get it out or get it in with a forceps can end up damaging the ICL. Here we were attempting to push it in and then see if it gets damaged, then we could, probably remove it. But with lot of patience and over almost 10 minutes, we managed to get this ICL, into the eye, and luckily we could retain it. But you are not always lucky, and sometimes the ICL will get damaged and you may have to then explant it. And avoiding this situation is the best. So, no wound-assisted injections is the take-home message from these 2 slides. Now, ICLs, as I said, we can always do better with slightly bigger incisions. And sometimes these incisions, once you push the ICL in, unlike the small 2.2 incisions, the 3 mm incisions can occasionally be leaky. 99.9% they are not. But it always makes sense to check. And if they are leaky and you don't want to suture them because you don't want to induce astigmatism, you can quickly do this supra-incisional pocket, which I love to do with my pediatric cataracts and some of these leaky incisions. So rather than struggling in trying to, seal the wound, you can just make a small pocket just above your main incision and see that my infusion is on with the left hand, and yet there is no leak. It takes just few seconds and it works almost every time. So I think this is another thing which I sometimes end up using if I have a leaky tunnel, which is very rare with ICLs. So again, not the take-home message that ICL tunnels will leak. Now, coming to another situation where sometimes you will have ICL which will try to open up upside down, so you can try your best, because if you watch the holes on the ICL and you're careful with your injection, this does not happen. But sometimes if you, while loading, you've not been careful and the ICL twisted inside the cartridge and you didn't watch for the 3 holes to be aligned in the cartridge, you may get this situation where the ICL can twist while being injected, and then you can always just pull it out of the incision like that, and you can again implant that ICL carefully. Now you'll see here that I'm doing a special wound assisted. I mean, I'm doing my cartridge tip is well inside, and I'm just making sure that it opens up the right side now. And then of course it should not be difficult. Once bitten, twice shy. I got this patient referred, another situation, and patient had an ICL done elsewhere with both eyes. And one eye, of course, was doing well. The second eye looked like this. I was suspicious of what's going on. I looked like that. There was a big PI and had been operated by another colleague. And this is how the OCT looks. Obviously, you can make out that this ICL has been implanted upside down. And it obviously has to be explanted as soon as possible. So I told the patient that you need an explant. However, the patient went back and the surgeon said, no, your ICL is fine. And, he was not ready to explant it. I almost had half a mind to call him up and tell him that please do it. Otherwise, I'll do it myself. However, the patient came back after a week saying that I've got my ICL explanted. But this is what it looked like. The capsule was ruptured in the middle and there was a big ring-shaped, fibrotic anterior capsule. So, we had to then, of course, go ahead with the cataract surgery and, it becomes a complicated situation. So best thing is to be sure to watch the vault on day one. We do an OCT, anti-segment OCT for all our patients on day one post-op. Obviously, you can see it on the slit lamp. You don't have to do an OCT to see that. And be very, very sure, just like in the previous talk we heard and we'll hear in the talks ahead, to watch for the vault of the ICL. Ever since we have a central hole, it's become very rare to get, cataract. So even, these holes will prevent cataract formation in 90% of the cases, even if you have a low vault. But in upside down ICL is a total contraindication. Coming to my last case for today, there was this patient who was a 25-year-old male with these spars. He had a cornea which was not very good for, we are using a lot of low-powered ICLs now, and I love to do ICLs now whenever the cornea is even borderline suspicious. So we went ahead with the first eye of this patient. And after that, it was an uneventful surgery completely. And after we managed to do the first eye well, when we went with the second eye, again an uneventful surgery, but on post-op day one for the second eye, which was done under topical anesthesia, the patient presented with severe pain in the morning. He was operated the previous evening at about 7 or 8 o'clock under topical anesthesia, totally uneventful surgery. And he called up at midnight. He was from an adjoining town, so he could not present to the hospital at night when he got pain. He had been given Diamox post-op and the routine regimen and everything had been done, the way I have been doing for so many years. But he came with severe pain and it was almost like a, almost like a panophthalmitis kind of a situation. Of course, his vision was 6/9, but his pressure was 70 millimeters. And there was diffuse 360 degrees, retrobulbar hemorrhage kind of a situation. And there was significant proptosis, and you can see the lid, how it was looking. He had had 6 or 7 episodes of forceful vomiting the previous night. Now, in my whole career, where I would have probably done not as many as Dr. Kudlu thinks, but maybe about 500-600 ICLs or a little more than that, I've never seen anything like this. And moreover, with topical anesthesia, we were not expecting. The first eye had been uneventful. So when we looked at him on the OCT, the vault was 568, as you can see here, but you can also see in the anterior chamber, some kind of inflammatory debris is visible. And we immediately managed him with mannitol, but it didn't help. He got 2 tablets of Diamoxstat and he was started on topical medication. After a couple of hours, when nothing was helping, we did a burp of the AC, hoping that, maybe if it is because of some viscoelastic residue. I went back and looked at my video. We record all surgeries. So I went back and looked at my video. The video surgery had been done exactly the same way as I would do everything, every patient. We had done a meticulous removal of the viscoelastic. So we ruled out that there should be anything over there. I was not in a rush for this surgery. On day 2, after the burp, the pressure had obviously come down to about 30. And we were hoping that we'll medically manage the patient. But on day 2, patient came back with a fall in vision, 636. There was a small epithelial defect with corneal edema. Pressure was still 60. And he was again administered mannitol. And, Diamox was now being continued since the previous day. But nothing seemed to be helping. So we decided, once, watched him through the day and, we took him up for surgery, just hoping to either remove the ICL or find a way of, sorting this. So this is what the surgery was. I've purposely not shown you the first surgery, but this is the way the surgery was. We managed to go in and do a good AC wash. The pupil had the iris had become floppy, and there was a little bit of fibrinous thing in the anterior segment, but otherwise it was clear. We repositioned the ICL a little bit. I tried to kind of move it and see if the foot plates were stuck or if there was anything else which was causing a problem. I'm just kind of queuing this video because I couldn't find the edited version just at the last moment. But we just went with, and then we stroked the iris and we tried to kind of go to the root of the iris and make sure that there is no, iris is not caught anywhere. We used intracameral pilocarpine to try and constrict the pupil. You can see that the iris is quite floppy there. And then after all attempts at, doing everything, we decided to retain the ICL for this time and made sure that the wound is sealed nicely. Now, post-op day one, this is how it looked. The vault had become a little lower, but the pupil was dilated, as you can obviously see over there. But the pressures had started to settle down, and the vault had now fallen to just about 263, and post-op at 1 week. And however, at 3 weeks, his vault came so far down, and we don't know why this happened, because the fellow eye continued to have the same sizing, same everything, and the vault remained absolutely fine. He recovered 6/9 vision, 6/18 unaided, and 6/9 with pinhole at this point. And so the change we've made in our surgery, and I'll just finish with this. We now do a hydroimplantation for all our ICL. This case is about 1 year back. So we do all the steps the same way as we would. But now we've started doing hydroimplantation in all our patients. You can see here we hold the left hand has the infusion, and the ICL is injected with no viscoelastic is used at any point. It's made a tremendous difference to our surgical results. Patients are very, very comfortable, no post-op pain, no instances of patients complaining about our vaults are much, much more steady. They don't change much over a period of time. We don't see any inflammation. Post-op day one patients are absolutely healthy and fine. And positioning the foot plate and everything is also quite predictable. Now, I will not suggest that any beginner surgeon attempts this at all. But if you have an experience of, say, about 100 odd ICLs and you want to try this, you can, once you are very, very fluent with doing it under viscoelastic, because you have a clear lens right there. You don't want any complications or mishaps happening. But we have done now about 150 eyes with the hydroimplantation technique and found it very useful. So with that, I'll finish here and stop sharing my screen, and I hope I was able to make a point.
Thank you so much, Gaurav. It is a fantastic presentation. Probably I also learned a lot of things, especially how you did the last case. I think so many things need to discuss. I think probably, if you don't mind, you may have to stay back for at least 2 to 3 minutes or up to 5 minutes.
Of course, I have 5-10 minutes, sir. No problem, because I have to run.
Main discussions for today, of course, two giants are there, Professor Tithyal sir and also Dr. Ramurthy sir. I think they'll have a lot of questions to ask you. I think over to Tithyal sir.
No question to be asked, because he showed beautifully everything so clearly, and he explained also. I think as far as surgery is concerned, as he rightly said, it is simple surgery. But once things go wrong, it can be very, very troublesome for a surgeon and patient both. And most complications do occur if you don't pick up things getting in a undesired side on the table. If you pick up right in the beginning, you can prevent the complication happening, especially the ICL unfolding in an improper way. That can be prevented. And he rightly said you should not try to flip inside, take out the lens if it is inverse opening, and then put it again, because explantation of ICL is very, very simple technique. And towards the end, he rightly showed that people now are trying hydro implantation of ICLs. And I rightly said it should be done with experienced hands only. Because as far as I am concerned, I normally would do sodium hyaluronate 1%, which comes out as a bolus, and I maintains the chamber a quite stable way while implanting the ICL. And unfortunately, we don't have a long-term data of what is the effect of things which are happening inside in a clear lens. What is the impact of a fluid running over the clear lens? We don't know ultimately what is going to happen. What is the impact of these viscoelastic onto the anterior lens capsule and subsequent things? Though whatever experience we have for last more than a decade now, we have not seen any adverse effects of a viscoelastic also, except for a methyl cellulose. Sometimes it coats the lens from behind, and I've seen some methyl cellulose getting stuck onto the lens anterior capsule, and it looks like a cataract in the beginning, but it goes slowly off from the visual axis also. So we have to really see how much flow has to go inside, because the flow turbulence can also hit the lens capsule, and that has to be maintained in the right manner. So I think Gaurav can explain what is the pressure, bottle height, how much fluid goes inside. Sometimes if you have too much of fluid, your wound is not proper, the iris can come out from the wound area while trying to inject, and that can complicate the pupillary area. So Gaurav can explain that particular part.
Thank you so much. I think that's one of the most important points, because if you have a high bottle height, obviously all these things, as you said, will trouble us. The iris will start popping out. There will be a high flow situation. The things will get a little uncontrolled. I am currently doing at a bottle height of 40 or an IOP of say about 30-35, and that's usually good enough, unless of course you have to be fully prepared. Now if you depress the wound and you are not able to block the wound with your tip of your cartridge, the chamber will suddenly shallow. Now that also is dangerous, because you don't want a suddenly shallowing chamber. So you have to be meticulous with your infusion on, and as you enter the wound, if the whole tip occludes occupies the whole incision, and you are blocking it and you start injecting, your chamber will not shallow. The moment you start injecting, the chamber becomes nice and deep. And of course, at all points you have to be very careful. Now suppose you abort the injection, or you are kind of stuck in between, there's a huge problem. You can have a big situation over there, and you can actually get stuck with no viscoelastic in the eye. That's why I said, only if you are very experienced and comfortable with the injection, this can be done. But we've found a way of doing it. The biggest advantage we found was, because after that case we realized that such a horrendous complication is possible. Even if it happens 1 out of 1,000 patients, you don't want that to happen. We felt that the post-op IOP spikes, which happen because of viscoelastic, have been totally eliminated. We've actually done a study of about 100 odd eyes with hydroimplantation, and compared them to 100 eyes with viscoimplantation at 3 to 4 hours post-op IOPs, and we found a significant difference in IOP spikes post-op with the hydroimplantation group. And we've been very happy. But yes, all comes with a word of caution, as Dr. Tityal sir said.
Gaurav, what about placing the ICL on the cartridge? Because the company recommends you have to coat the cartridge with the viscoelastic.
Yes, we do that, sir. We put a small amount. We put that diluted BSS plus a bit of methyl cellulose.
Otherwise, if the fluid is not there, it becomes a hydrophobic surface, and ICL can get stuck there.
Absolutely. No,
so you have to have an inner
for
coating.
that point, we are using it, sir. Definitely, we use it. But it usually gets washed out as you're injecting, because much of it is washed out as the ICL is going inside. So that is a trace of viscoelastic, so it doesn't really matter so much. But
Tityal, may I add in a few words here with my experience on hydro insertions?
Sure, why not?
Okay, so we have done quite a few hydro insertions, and for the last almost 1.5 years, we are doing totally on hydro insertions. There are a few points. One, when you said coating the cartridge with methyl cellulose, we don't do that now. We are doing that initially, but now we are just putting water, saline in it, and then we are loading the lens, and it moves out pretty fast because you are loading it and immediately pushing it into the eye. Number two, the incision with the cartridge has to be kind of locked. So your incision has to be 3.2 always. So your cartridge
Gaurav
goes
said
in and locks. Well, my personal choice. So that the cartridge is into the incision and it locks there well, so that the incision does not leak. Otherwise, all the points which Dr. Gaurav has said are just right. The results immediately after 2 hours makes you feel as if the eye is very quiet. We have never had a case where there was a rise of post-surgery IOP. No strands of viscoelastic seen anywhere. And the recovery is just uneventful. So it takes a whole lot of strain out of the system that you have to put in methyl cellulose, and then you have to meticulously remove it, not only from in front of the ICL, but from behind the ICL. And whatever you may do, some viscoelastic gets trapped between the ICL and the crystalline lens, and that is very difficult to take it out. So sometimes when you finish to irrigation, you still see some strands of viscoelastic coming out through the central hole for quite some time, almost like a wick coming out.
I think many people do use 1% sodium hyaluronate as a viscoelastic, which is very handy viscoelastic. Comes out as a bolus, and even you have a viscoelastic underneath the ICL, you don't have to aspirate from underneath the ICL. That will damage the lens capsule. It is from the anterior side only, And the people should not try to take out from behind the ICL, because you have a hole now in the center periphery. You can aspirate from there also. That will prevent the damage. I think methyl cellulose should be avoided as far as possible.
And sir, I don't want to give anybody this take-home message to start doing hydroimplantation, especially the beginners. It would be totally wrong, and I would feel dreadful if somebody goes and starts doing it like this without having a 200 ICL.
You can have a massive problem sometimes.
Yes, so I think the
Gaurav,
message
that's a very nice message from you. And what will be your viscoelastic of choice if we suggest the beginners? So what do you recommend? The viscoelastic.
I think Sonu, as sir is saying, because we started off by being told that you must use methyl cellulose when ICL was first started, and they actually told us not to use sodium hyaluronate. But then studies came out which were proving that sodium hyaluronate works really well. And as sir has said, I think it's a great idea because sodium hyaluronate actually comes out in a bolus, and removing it is not difficult. So everything makes sense. And of course, I have not used it, but I will trust sir's experience on sodium hyaluronate, and I would recommend probably sounds much better than methyl cellulose.
Yeah.
So
I never had IOP spikes.
We've all learned from sir, and he taught us. So we've learned to use sodium hyaluronate, and we've been always using sodium hyaluronate. And actually, it comes out in a bolus, comes out very easily also.
That's the biggest advantage of being non-retentive in the anterior chamber and not causing secondary IOP spikes.
Yes.
So yes, Krishna Prasad.
Ramurthy sir wants some comments from his side.
Yeah, I think Gaurav made a fairly good series of presentations and a good discussion that followed. As far as the size of the incision itself is concerned, I cannot agree more that I make 3 millimeter incision, and I actually want the tip of the cartridge inside the anterior chamber. Apart from the reasons that you alluded to, that also gives me very good control as far as the opening of the lens is concerned. I'm able to visualize the lens adequately. And as regarding the reverse opening of the ICL, it's important that we are constantly looking at the leading right haptic and make sure that the mark is over there. And just in case you are using an Indian Phakic IOL, that would have a mark in the leading left haptic, and you have to be cognizant of the fact that these two things are a little different. And just in case it seems to be opening up in the wrong direction, by just a slight twist of your hand, you can usually make it open in the right direction. But in case it continues to open, you must remember that even when 7/8 of the lens is inside the anterior chamber, still if you withdraw your cartridge, most often the entire lens will come out. So you need not go through the pain of removing the lens, but remove just the whole cartridge, reload it and go in. But as was said, flipping the lens inside the anterior chamber is something that needs to be totally avoided. That's a strict no-no. And just to avoid this lens opening up in the wrong direction, I think it's extremely important that you load it the right way. Sometimes what happens is after putting the lens, when you pull it with the front loading forceps, it's slightly angulated. So the lens is somewhat flipped to one side. So if you pull it directly straight and you observe that it's flat in the cartridge just before injecting, it's opening the cartridge inside the anterior chamber, going in a straight direction, then most often you do not get this problem. And regarding that very difficult case that Gaurav showed, about which there was not much discussion, I think the 3 reasons why intraocular pressure rises in the postoperative period. One is a high vault, which obviously was not the case in his surgery, because he showed OCTs which showed that the vault was just about 500 microns even in the initial post-op period. Second thing is inflammation. It was a quiet surgery, and this happened right on the first post-operative day. So obviously, even though he says that all the viscoelastic was removed, it's retained viscoelastic which has caused this. And there has been significant discussion on this. And that's the reason that going back and washing out this viscoelastic has made these eyes settle down, though it's difficult to explain why the wall went down in the post-operative period. But having said that, we have to be very careful of the fact that if you are using viscoelastic, especially HPMC, you have to wash this completely. It might take a couple of minutes of doing this, and you have to be very careful while doing this also. And I did not learn it from Tityal, but I'm doing it in the sense that I've also almost completely switched over to Helon. And I find that this cohesive viscoelastic just flows out as a bolus. Very often, I don't even have to go in with the aspiration cannula. Just after the intraocular, the lens is placed in its right position, just a slight depression on the lips almost allows you to, allows the entire viscoelastic to flow out. And of course, as far as loading the lens is concerned, I put still a drop of HPMC, because if you use Heal-On in that, then that's too tight, and the movement of the lens within the cartridge is not so good. But there's very little HPMC going in with that. So I think overall, most of the other points are already covered. Good series of complications that Gaurav showed. And most important aspect, maybe the take-home message would be an adequate incision, and then ensuring that good viscoelastic removal is done. And maybe you can resort to Heal-On. And of course, if you are very comfortable with the implantation of these lenses, hydroimplantation is a good way to go, because that entirely takes the equation of HPMC or Heal-On out of the equation.
Thank you, sir.
Can I ask one question, Dr. Kodlu? A quick comment. Hello?
Yes,
yes,
Dr.
please,
Purender.
go ahead.
Yes, please.
Yeah, but do you, Dr. Gaurav, did you use pilocarpine in that particular case where the rise in intraocular pressure is there? Because we should leave the pupil dilated at the end of the surgery.
Right. Now I don't, for many years, I don't use pilocarpine. Maybe last 10 years, I'm not using pilocarpine. And only in the second instance, when we did the AC wash, we were trying to constrict the pupil. At that point, we tried to use pilocarpine, but it didn't make any difference. It didn't help. So, because it had already become a Uret Zavalia kind of atrophy. And
what is the final status of the pupil in this case, Gaurav? Did it remain dilated?
A little bit. So it has come down to the edge of the optic, but patient is luckily, fine. I was planning to do a single pass 4-through over the ICL, but because the vault is very low, I decided not to do it, because I'm hoping, it's 1 year post-op, patient is developing some early cataractus changes now. And I've already counseled him long back that he will need it. But right now pupil is at about 4.5, 5 mm, and he's managing with about 6-12.
Flare must be a problem. This is
it is, but I gave him the option of doing a surgery. He's decided to hold on for now, but he's prepared for a cataract surgery in due course. When I will do a cataract, and I will probably put a single pass 4-through as well to make the pupil smaller for sure.
So
thank you so much. I'm grateful, and I'm sorry for breaking order.
You are all very wonderful for getting those beautiful points and tips for learning. So next in the line, I would invite our young dynamic scientific committee member, Dr. Parikshit, to please introduce Dr. Kapil Varma, another doyen in ophthalmology refractive surgery, and he'll be talking on uncomplicated ICL surgery. And Dr. Sudhank Bharti and Professor Namrata Sharma will be the expert panel. So all to you.
Since Dr. Parikshit could not log in, he's still busy in clinic. It is my pleasure to introduce our next speaker. As Sonu has already mentioned, Dr. Kapil Varma is a very well-known and senior ophthalmologist. He is a medical director and foundation and the founder of Kapil Eye Hospital. He has conducted thousands of surgeries across the country of course in his own hospital. That is very obvious. He also worked as research officer in ICMR Department of Ophthalmology and Medical College, Bhopal. Earlier in his career, he was a lecturer also in MGIMS in Wardha and served as chief eye surgeon in the Philadelphia Hospital, Ambala City for several years. His achievements include he's the secretary of Haryana Ophthalmic Academy, and most importantly, he was also awarded and recognized by the IIRS President Gold Medal and the Dr. Om Prakash Gold Medal. So we hand over to Dr. Kapil Varma to give his talk, which will be almost sort of a mastery of how to put in the lens into the eye, the ICL into the eye.
Evening, are you able to hear me?
Yes.
Yes, sir, loud and clear.
Thanks for the kind words. And this is in a movie format. Can you see my screen now?
Yes, sir.
Yes. Okay. Okay. All right, sir. So just to say a few words before I start, that we have been doing the ICLs for such a long time now, all of us, that we all have developed our own techniques, and a few modifications here and there are still safe. And now I start with my presentation. So we'll cover it under 3: immediate preoperative preparation, ICL loading, and the surgical technique. One thing I would emphasize upon is the very sharp blades and perfect instrumentation, and we have to examine our disposables and instrumentation prior to the surgery. So this is a drag. This can happen even with the new knife. Please don't use such knives. We have to use very good knives. These are the disposables which you get along with the ICL. These are a multiple use injector, a single use foam tip plunger, and a cartridge. So make yourself aware with this. You might need one of these tuckers to tuck the haptics of IOL. And the most important thing is be aware of the orientation of the lens, the leading right and the trailing lower left. These have marks, and whenever the lens is opening, we have to make sure that these are opening in the correct orientation. So proper loading is essential to prevent damage to the delicate ICL and proper insertion. So this is how I load my ICLs. I still use the foam tip plunger to take out the ICL from the vial, balance it onto that, and then I put it onto the cartridge.
Kapil sir, your video is not running.
Video is not running.
It's running.
It's running for us. It's running.
Okay.
Running very well.
Sir, it's fine. It's fine.
Should I continue?
Yeah, please.
Okay. So this is how the ICL is to be loaded. Then you can take an ICL forceps, catch hold of the leading optic haptic part of the ICL and just pull it gently and leave it a little short of the tip of the ICL. I have to push it back now here slightly. And then this is the injector, and this is the foam tip applicator or plunger, which is being inserted. And once this is fixed with the click sound, we can now put the cartridge and lock it. And this is how it is loaded. So this is the surgical technique which I use. This video is around 15 years old. A slight slanting, one port I make only. And this is 1% lignocaine which I use. And at this point of time, I inject methyl cellulose. I still use methyl cellulose. And giving support to this, with the main port, you have to be very, very careful. And once I have pierced the decimates, become even more careful. Use 2.8 to 3 millimeters. And here I make the chamber still deeper. I will tell you why, because this technique has helped me. Now, a small part of the tip, as we were discussing, it has to be inside the anterior chamber and wait for the ICL to open up. So this has opened up with correct orientation. You can see the trailing haptic with a mark. There's another insertion. Again, I'm going very slowly, but here, since the wound was small, I was extra careful. And I saw that this ICL is not opening somehow. But then I saw the leading right and the orientation was correct. So I waited, and many times it needs a slight nudge so as the ICL opens up. After this, I still use the main wound to tuck the trailing haptics, and while trailing this, we lose some of the methyl cellulose, and it becomes again very convenient to tuck the leading haptics in. And I use only single port. I don't make two side ports. The lens is oriented, and then this is I am pressing the wound to make the methyl cellulose escape, the viscoelastic as much as I can. And then the irrigation and aspiration, I still use coaxial, and I am very comfortable with it because it helps me remove the major portion of viscoelastic. And this is where actually the surgery stops nowadays. But as you must have noticed that this lens has no central hole. This was a pre-Evo era lens. So this is where the surgery stops nowadays. You don't even inject pilocarpine. But in hyperopes, that is why I selected this. You still have to make a peripheral iridectomy even nowadays. So after putting some pilocarpine, I wait for the pupil to constrict and then make a mid-peripheral iridotomy in case of hypermetropes. Again, some irrigation aspiration, and your surgery is over. So, some wound hydration. And in the post-operative phase, you have to check the vault, which in my case, I'm very comfortable if it is around 250 and above. Thank you.
Thank you, Dr. Kapil, for that wonderful presentation. So can you stop sharing the screen, sir?
Yeah, sure.
So over to Professor Dr. Namrata Sharma and Dr. Sudhank Bharti. Ma'am, your quick comments.
I think Dr. Kapil Varma, the hurricane from Haryana, as his own, does all surgery so quickly that, before you just blink, it's already over. So
True.
great surgeries, I should say only a few points. If you're just beginning to do your surgeries and switching over, say from cataract surgery to ICL surgery or phakic lens surgery, you have to unlearn your steps of phacoemulsification. Like when you're making a wound, you can't, dive down, because that is your instinct when you do a cataract surgery. You have to fly like an aeroplane, up, so that you don't hit the lens. Also, when you're making your incisions, you cannot be radial. I think beautifully demonstrated by Dr. Kapil Varma that, you have to make them slightly straight and not make them radial at all. The loading of the lens was, I think, very elegant, shown in a very elegant manner, and he didn't show viscoelastic. I normally would like to put viscoelastic first into the cartridge from the front and also from the back, and then put the lens. But I think some people can just do it without. And then and as you pull it gently, the other hand also, moves in the opposite direction. So it kind of just helps you to pull it better, because ICL is a material which has some kind of a resistance, doesn't get pulled that easily. And then of course, whenever you put that, you've loaded the lens already, you have to put it in a bottle which has saline till the time that you make the incision. When the pupil is very dilated, sometimes it becomes very difficult, because you can't make out where your iris is, and then you can't make out whether the haptic is actually, or the leading edge or the trailing edge is actually tucked inside. So I think that can be one tricky situation. But and of course, like I always say, and Dr. Tityal sir has also published a study, and we've done it, where if you have an intraopposite microscope, you can actually see the vault of the lens, and you can see whether the vault is adequate or not, and also can see whether the viscoelastic has been completely eliminated from between the lens and the crystalline lens or not. So that is a useful tool to have if you are, a beginning surgeon.
Thank you, ma'am, for bringing so nicely those wonderful points. Yes, Dr. Bharti, sir.
Yeah. So first thing, Kapil, a wonderful surgery. I must appreciate. This was a very nice demonstration of the ICL surgery. Couple of things which I would normally do and want to, kind of convey to the audience. One thing is that I think what was earlier said is 3.2 incision is wonderful. Minimum 3 one should keep, because the cartridge should enter the tunnel and not remain. Tunnel should not be used for injecting, because if the ICL opens outside, it's a big mishap, and then while injecting or taking it out, it is possible to kind of damage the ICL. About the loading, what I do is I put a little bit of viscoelastic on the edge of the bottle. And then if you take the ICL out, the ICL is already painted on all the sides with the viscoelastic. So if you hold it with the wick, which is given with the ICL will never fall, because a couple of times it happens that if it is not sticking to the wick properly, injector properly, then it falls and you don't have at that point in time a replacement of the ICL. So that's what I have seen, that that gives a lot of confidence. Even if the ICL slips a little bit, it doesn't fall at all. Also open the ICL over the eye and not beyond the sheet, so that even if it falls, it doesn't fall out on the floor or somewhere where you cannot pick it up and use it. The second thing is, what I would do is I would inject half of the cartridge with the viscoelastic. The HPMC is the best, and then fill it up with the BSS, so that the HPMC is diluted about 50% or more, or maybe 30% HPMC is only there, and then you can kind of inject the ICL. I always inject it with the viscoelastic, but as soon as I've injected, because I'm very particular that the AC should not, kind of get shallow while I'm injecting. Third thing is when I have injected the ICL, I press the inferior, lip of the main port. As soon as you press the inferior lip of the port, the viscoelastic from behind the lens comes out. It is not from the front that comes out first. It comes out, what comes out is from behind the lens. And that is the most crucial thing, that you take out as much viscoelastic from behind the lens as possible. And then while washing, keep the irrigation port right in the center, aiming towards the central fenestration in the ICL, so that whatever, and you can really watch it. As soon as the flow of the fluid, the BSS goes through the hole, you can see that the viscoelastic is getting spread, and you can see that in the center there's is coming and BSS coming in the behind the lens, and then you see that everything is getting washed out. So those couple of things will take care of post-op rise, post-op inflammation, post-op fibrin during the after the ICL. So those couple of things you have to be very careful. And then the best thing which I appreciate is the incision, side port incision, which was made by Kapil. It was directed towards the iris and not towards the lens. Both ways it is safer, and also it is not radial incision, but the direction towards the iris. It gives you a more controlled, possibly rotation of the ICL, because your direction towards the periphery and not towards the center. That is the very crucial thing which Kapil said. Wonderful video, I must appreciate. Thank you very much.
Thank you, sir. So I would just chip in to bring in a point. He beautifully demonstrated the way to do a PI in cases of hyperopic phakic IOLs, which do not still have a central hole. Namrata ma'am, would you do a vitrectomy cutter, a PI, or you would use your forceps? I mean, what is your choice of doing a PI?
So when we were using lenses which didn't have holes in the center, we were doing a PI with a YAG preoperatively for all our cases.
Bharti sir?
Excuse me. What I do is I do it with a vitrectomy cutter and put the cutter at a rate of 10 with the Alcon machine. So it starts sucking the the periphery of the iris in the port, and then cuts once, and that gives you a wonderful PI, which is very nice. In hyperopic ICLs, you must do a PI. YAG PI, you have, I think once a couple of times my YAG PI is closed after 7 days. So, and we were planning to do a YAG PI before 7 days before the ICL surgery. So that is why I would rather prefer a larger PI with the vitrectomy.
So I think points very well brought, that it differs from the cataract surgery. It has not to be the wound assisted. And as rightly said by Namrata ma'am, the direction is very important. You don't have to direct it towards the lens, but towards the cornea. So I think, thank you, Kapil sir, and thank you. Yes, sir, quick. Yes, sir, Ramamurthy sir, please.
Yeah, it was beautiful video, Kapil, and the direction of the incision, was very well illustrated. But though I have not had this problem in ICL, I've had cataract patients where I've touched the lens capsule with while making the incision and created a small nick in the anterior capsule. Obviously, if it's an ICL, the case is over if that happens. So nowadays, what I do is not to dilate these patients at all preoperatively. I just make the 2 side ports, then fill in a little saline so that the pupil doesn't even dilate, and make the main port, and then inject Xylocard or Phenocaine. And these myopic patients, the pupil dilates very well. So my incisions are made with the iris coverage so that the touch of the lens capsule is sort of avoided. And as regards Namrata's comment about the hugely dilated pupil, that's because of excessive fill. Whenever I face that problem, I just burp out a little visco, and you find that the pupil comes down and the edge can be seen.
Points well taken, sir. Yes, sir, Partha, sir, please. Sir, you have to unmute, sir. Sir, unmute, sir.
Yeah. Okay, so just one or two small points if I could make. One is about we learned the phakic IOL or the ICL with the methyl cellulose, and it was a very standard teaching the optimal fill of the anterior chamber. So how that is how we learned is to put in the methyl cellulose and see the strings of methyl cellulose, and once they were coalescing with each other, to stop at that point. So the overfill is avoided there, and also the underfill. And I also personally tap the eye a little bit just to see it's not overfilled, because an overfilled methyl cellulose, then the ICL does not unfold itself very well. Whereas if it is optimally filled, it unfolds very nicely, and you can see not only the right foot plate going in and the mark on the right foot plate, but also the holes, which should be absolutely center and on the top. So if it is a little on one side or the other, you can, as very rightly said, the wrist can be turned and you can have the ICL folding right off. The other point that I wanted to make is about the PI. The hyperopic lenses do have the PIs that have to be done. Now, I use a slightly different technique, and I try and make the PI a large one, but at the periphery. So how do I do it is, like I approach the root of the angle by directing my side port from the cornea to the root. Meaning it is absolutely reverse to doing a PI, what we do in a cataract incision. So it's from the limbus to the cornea, whereas here the PI is directed from the cornea and directed towards the root of the iris. Thereby, I'm approaching the root of the iris, and then I pick it up with limbs forceps and do a PI, which is nice and large, yet hidden from view. So this is a small technique that we had described, and it was published also, and it works extremely well. One thing you have to be very careful, you should not tug the iris too hard, otherwise you might have a bleed, or you might actually damage the root of the iris. Third thing, a quick comment from maybe Dr. Ramurthy sir. Dr. Ramurthy sir does a large number of IPCLs also. So we've been talking about ICL, which has been there in a very time-tested lens, but the IPCL is also a lens that is widely used in India. And so if you could comment about the IPCL maybe.
Partha, you're forgetting the sponsor now. Anyway, Dr. I know your comment is going to be guarded after this.
So you're putting me on a spot.
Yeah, I'm putting pressure on you.
I use both ICL and IPCL almost in equal measure. So appreciate both the lenses. And I believe that the Indian phakic intraocular lenses are also pretty good. They have come of age. And the only concern I used to have is that while the ICL is tried and tested material of Collamer, while these lenses are made of hydrophilic acrylic, but now having experienced these lenses for 6-7 years and is widely used across the world, I have no hesitation in using these lenses. As I already mentioned, one of the concerns you must have is that the stud that you have to indicate the right opening is on the left leading edge in the IPCL, and you should be cognizant of that. While in ICL, the hole is in the right leading edge and the right haptic. And secondly, what I find is that as far as loading of these IPCLs are concerned, no viscoelastic is to be used. Basically, you just use BSS, and there is a coating within the cartridge itself. And that sort of mixes with the BSS, and that allows for free passage. And in case you have used viscoelastic, you often find that the injecting of these lenses becomes a little difficult. The injectors that come with these lenses are not as good as what comes with ICL. That's the reason that most often these manufacturers give 2 lenses at the same time, and you once you are not used the second lens, you return it back. And secondly, many of these lenses are custom made, and in case you have extreme powers, you can again pre-order these lenses and get them. Even high astigmatism up to 8 or 9 diopters have used these lenses. And as far as the optic size of these lenses is concerned, that's even bigger than the EVO lens, which is 6.1 millimeter. That's obviously an advantage when you get high mesopic size pupil, and sometimes you can get even bigger size than that. another advantage is these lenses are just 0.25 millimeter steps. So sizing these lenses can be even quite accurate, and no rotation is necessary in toric lenses because you can place these lenses in 0-180 degrees axis. So I believe that it's again good that we have choices, and the ICLs with its time-tested technology, more than a million lenses, 30 years of history, it's a great lens to be with. But it's good to have our own indigenous lenses which are more cost-effective and which are again getting proven to be quite accepted as far as the patients and surgeons are concerned.
Dr. Ramamurthy, any experience of explanting these lenses? Any experience of explanting these lenses?
Yeah.
As it is ICL?
ICL, yes. I have expanded both ICL as well as IPCL. Both these lenses do come out through a 2.8 millimeter incision itself. And all I do is to just pull out one haptic and then go with the front loading forceps itself and just catch hold of that and bring it out. And it just folds on itself, both a hydrophilic material. So it folds on it and easily comes out.
Do you think there's a difference in ease of explantation of ICL vis-a-vis IPCL?
I really have not done a study in that because I fortunately have not explanted so many lenses, but then I really have had no problem. As far as I'm able to fill in the anterior chamber nicely with a viscoelastic, I don't even bring out the entire lens into the anterior chamber. Just to go through a side port and prolapse out one haptic, and just go in with the front loading forceps and just catch hold of it. And then with a hand over hand maneuver, bring it out. And I find that both these lenses come out equally easily.
Last quick question from the audience to Dr. Kapil Varma. If you have patients with large pupil and you're planning a refractive procedure, so what would be the procedure of choice? Would you still continue with ICL?
Maybe no. I would not like to put even an ICL in such case, and even LASIK will be a risky proposition in such a case. And actually, I would also like your opinion, but many a times in the borderline cases, I prefer ICL over LASIK.
So I think with the new Evo Vision series, they have on the corneal plane, they go as high as 7 millimeters, which by any refractive platform, we can't really approach. So I think Evo Vision could be a wonderful suggestion in these large pupil patients.
Evo Plus varies from 0.3 to 0.7 millimeters. A wider optical zone. Maybe it takes care of many patients, but still what I have seen is that in such a case with very big pupil, if you do a LASIK and versus the ICL is better tolerated. This is in my experience what we have done here.
No, I think what Sonu was mentioning was that when you have 6.1 millimeter optic diameter, the effective diameter that you get on the pupil is almost 1.25 times.
1.25, yeah.
Makes it about 7.5 millimeters.
Yeah.
But in these large pupils is one indication for me to go for a Indian lens, because here you can get custom-made lenses without really enlarging the overall diameter. You can have the optic size as big as 6.8 millimeters even.
So I think
custom-made lenses in such cases, sir, and they do behave well.
Yeah.
I think lens-based procedures would be much better off than the corneal-based procedures in a large pupil size. That is what
I do agree. Yes.
Otherwise, also I think the contrast sensitivity and the abrometry values are much better for lens-based procedures as compared to for LASIK procedures.
Very true. So thank you, Kapil Varma, sir. Thank you, Dr. Namrata. Thank you, Dr. Sudhank Bharti. And yeah. A quick word from Dr. Pupil, sir. Yes, sir, please.
Dr. Soapshila asked me the role of phakic IOLs in pediatric population. But well, I'm not very enthusiastic about using a phakic lens in a pediatric population. I would certainly like to know about the expert panel on this. I have not used and I'm not very keen on using. But what's the opinion of the other panel?
So I've been using for amblyopic patients, sir, where an isometropia is there, and the population has really improved and they really work well. Dr. Mahipal, sir, any quick comment for this, sir?
Yeah, so on pediatric cataract, all that I'm trying to say is that even though we are not getting cataract to that extent, but now since it's been almost two decades, we are getting cases even around 40 years of age. So 35 to 40, 42 are developing Have any scientific literature to support that, but that's just a little feel that I'm getting, that maybe it might induce, because after all, there is something that is sitting on the lens, even if it is in the periphery. It's not in the center that's happening, but it's in the periphery, and there could be some small little changes which are happening, which could actually do that. But overall, I think even if a cataract comes, it's really not a problem to remove this lens and do a cataract surgery, because there's no problem in IOL power calculation, etc., etc. So that's a much better problem to have than having a problem of corneal ectasia or something like that. So,
sorry to be taking up time, but since you brought this up, I mean,
sir, looking to the paucity of time, I'll shift to the next. Sorry for that, sir. Thank you, sir. So now we have in line Dr. Sagar Bhargav, and I will introduce Dr. Sagar. So Dr. Sagar Bhargav is a senior consultant in the BBI Foundation, Kolkata, and director in the SLR Eye and Retina Surgeons Private Limited, Kolkata. He was the university topper in the first MBBS and won several awards. After finishing his MS, he joined Shankar Nethralaya, Chennai as a fellow and then the consultant, and he was recognized as the best associate consultant in 2008 in Shankar Nethralaya. Besides his clinical practice, he is now actively involved in various academic activities and has many presentations and publications to his credit. And I would like to invite Professor Tatyal and Dr. Sanjay Chaudhary to please be the expert panel for this presentation. Dr. Sagar. Sagar, I think you need to unmute yourself.
Yeah, is my screen visible? Am I audible?
Yeah, you are both.
Yeah, you are audible.
Yeah, thank you. At the outset, I would like to thank Dr. Partha Bishwas and AIS Scientific Committee for giving me this opportunity. It's a privilege. So the topic that I'm going to do is toric ICL. So as we know that toric ICL, the pre-ICL work has already been dealt with very nicely today. But I would just like to give some emphasis to the points which are relevant to toric ICL. The first very important point is that if the patient is a chronic contact lens user, it's preferable that patient should be off lenses for 2 weeks before you do the evaluation for these patients. You also need to do dry eye assessment, simple tests like Schirmer's, T-BUT, and corneal staining, just to make sure that this ocular surface issues are not changing or not affecting patient's refraction. A tomography would be required to just rule out subclinical keratoconus, and you need to correlate also the axis and magnitude of the cylinder. The fourth important point that we have to remember is that when we are putting toric ICL, we are actually treating the spectacle astigmatism and not the corneal astigmatism, as is the case in toric IOLs. Now, to explain this, let me give you an example. This is a 28-year-old high myope with who was using -10, never used any astigmatism correction, but see the retinoscopic value and see the keratometrics, a very high cylinder. Now, how has this happened? So a topography would give you an answer for this. So you can see a hot spot there, just superior to the center, and that was good enough for the instruments to pick up a cylinder, but it did not cause any effect on patient's refraction, and patient was just needing a spherical correction. So in this case, we just went in with a spherical ICL, and this hot spot was because of some subtle opacities which were present in the patient's cornea. So this is very important to remember, that you have to basically aim for a spectacle astigmatism correction rather than corneal astigmatism. Now, the next important point is marking. So marking is essentially just like a standard toric IOL, which all of us are absolutely used to doing. and use whatever the technique you are comfortable with, be it slit lamp, be it bubble marker, be it smartphone app, or be it digital marking. I, for one, usually use a smartphone app by Dr. Patwardhan, which is very convenient and very easy to use. And off late, because of availability of Varion at our center, I have now shifted to digital marking, which removes all the hassles, and it's very convenient. So let me share with you a case. This was a 36 to 35-year-old lady who came for an opinion for ICL, and this was the refraction of that. She was wearing a glass of -16 with 1.25 cylinder in right eye and -11 with 1.5 cylinder at 180 degree in the left eye. The visual acuity was 6/24 and 8 and 6/9 and 6. And the first thing we advised was to discontinue contact lens for 2 weeks, and we called the patient again. And look at the refraction that has changed. Almost one diopter increase in the sphere in the right eye, and cylinder also increased in the left eye. There was an increase in cylinder. We did a white to white measurement using Aladdin tool, which we have been using for last almost 4 years, and we find this quite convenient. It gives you both manual as automated as well as manual. Manual, if you feel that automated is not up to the mark, you can just adjust it and get the values. And this was how the topography looked like, an absolute regular astigmatism, and pupil size was also quite okay, and all the other measurements were within normal limits. So we started, we planned for an ICL for both the eyes, toric ICL. So this is how the lens power calculation sheet looks like. And when we take the patient in the OT, we have to use this, what is called as implantation orientation diagram, which is slightly different from an toric IOL. So here, the concept here is that the company people will tell you to kind of insert the lens with respect to the horizontal meridian. So it either you have to rotate it counterclockwise or clockwise, depending, and the degrees is what they will inform based on the calculation. So here there is a counterclockwise 16-degree rotation in which we need to implant the lens for the right eye. Now let's look at the video. So we just seen the various insertion techniques. So I have my own little modification of the insertion technique. I don't use the forceps at all. In fact, I just load the lens and do a very small nudges to just push the lens in. I've been using this technique for almost a couple of years, and I find this is very convenient for me, because I always fear that pulling the lens out with the forceps, might tear it or something might happen. So that technique works for me. Just gentle nudges and just bring it to the tip, and then it's ready for implantation. So here we are just marking about 15 degrees, and this is the lens which is coming out now. And I use a iris spatula in the other hand, and just to make sure that there is a gap between the lens and the cornea, just to keep it away from the cornea. And the same iris spatula, you can actually push it in. You do whatever technique you are convenient with. But the idea is that you need just gently nudge the foot plates behind the iris, and the lens gets into the position. And the marks are there, so you basically need to now orient the marks, and we do it in irrigation aspiration mode. And it's not very difficult to rotate these lenses, and the advantage here is that you don't need huge rotations. The rotations are usually between 10 degrees or 20 degrees. So it's a binomial method. You can just rotate the lens and bring it to the desired axis. So this was the endpoint. Here the issue here is that you should not allow the anterior chamber to collapse at the end. So just to make sure that everything is fine, and a little burp maybe just to make sure that there is it's not overinflated. And we did the other eye also of this patient, and we got a good result. It was a plano in 6/9 and 6. And this was the vault of the right eye around 524 microns. So I would conclude by saying that toric ICL definitely gives a very predictable outcome. Preoperative refraction is the most important thing. So a lot of due diligence should be given to preoperative refraction, and toric IOL marking technique should be mastered before you start doing toric ICLs. I think that's it. Thank you for your patient hearing.
Thank you, Dr. Sandhya, for that wonderful presentation. I think you brought in very important key points for the toric ICLs. So now I would request Professor Tatyal and Dr. Sanjay Chaudhary to please put in their expert comments. Yes, Dr. Chaudhary.
Okay. Yeah, okay. So there are two things which are very notable in your presentation. One, the power of this eye was -17 with 2.5 cylinder, a minor cylinder. So if you have to transpose it it becomes 19.5 with 2.5 cylinder plus, right? Now the question is, an ICL maximum power is 18. And so 18 spherical with a 2.5 cylinder is what you could have possibly used, because you didn't exactly mention what power you finally used. So the question now comes is that what should we correct? Should we correct more of the sphere or should we correct more of the cylinder? Because every diopter of cylinder you correct is actually 50% of the spherical power which you would correct. So you have to come to a balance and still give the best effective outcome. What I normally tend to do is that if I would have a situation like this, I would leave, say, about 1 cylinder residual and aim for the maximum spherical correction so that 1 cylinder is fairly acceptable by the patient and he gets the maximum advantage out of it. Because had I targeted a full sphere of -18 and I used an ICL of -18 sphere, the residual would have been 2.5 cylinder, which would have been very troublesome. And had I used a full 2.5 cylinder as correction, the residual would have been a spherical of almost 2, which the patient would not have been very happy about. So you have to strike a balance in between. So what did you exactly use as a power, Sagar, in this case, the final ICL power?
So the final ICL power that was recommended to us was -18 with a +2 cylinder at 100 degrees, sir.
Okay, so you're correcting more of the cylinder.
Yeah.
And effectively you would have less power on the spherical side, right?
Yeah.
Okay.
We were expecting some residual myopic error in this patient, but surprisingly, the patient, we have been now following this patient for almost 6 months approximately. She has not accepting any myopic correction actually, and she's very comfortable with this plano. I mean, she absolutely refuses to accept any minus. We were expecting around -1 residual thing in this, but patient doesn't accept.
Okay. Now the second thing, which sometimes is very noticeable in these high powers, is the gain in visual acuity.
Yeah.
The gain in number of lines that the patient would have in these high kind of numbers, especially when you're correcting the cylinder power, which is almost 2 that you corrected, with almost no cylindrical power left. So the patient started off with a vision of 6/9. So was there 6/12 in the right eye?
Yeah. So when patient came to us, patient was just 6/24, but it was an undercorrected refraction because patient was a chronic contact lens wearer. So we put the contact lens off for 2 weeks to get the exact refraction. So with the exact refraction, she did achieve 6/9 vision. So the potential was there.
After the patient had a change in number, and you had a final refraction on which you ordered the ICL. What was the visual acuity at that level?
So that was 6/9, sir. It improved to
6/9 before the ICL.
Yes, sir.
Okay, so you could achieve 6/9 before the ICL.
Yes.
And then after the ICL, it was still 6/9, or was it
6/9
still?
No, it was 6/9, sir. 6/9.
Okay. Because a number of times it is noticed that most of the cases get a 1-line improvement, and many a times a 2-line improvement if you're not getting it on a spectacle correction.
Right.
So this is a real second big advantage of an ICL. So it is a high myopes where you in any case can't do a LASIK. For them, it is such a dramatic change in their life with an ICL that they just can't believe that something like this has happened to them in life.
Absolutely. And I have had some experience what you are saying exactly, that 6/18, 6/12 never had 6/9, 6/6 vision, and actually they turn out to be 6/9, 6/6 post ICL. So that really happens in some
I would request Dr. Tatyal sir to please put in your points, sir.
So first of all, I should say, Dr. Sagar, you passed the Viva exam very, very comfortably. through Professor Sanjay Chaudhary. And you showed a very nice case also. As well as everything was very nicely highlighted. Congratulations for that. 1 or 2 points for a toric implantation, especially if you're using ICL lenses. Once you implant the lens, before you take out the viscoelastic, the lens has to be in a proper axis. Because after you remove the viscoelastic, then try to rotate the lens, very difficult. Then you have to use a bimanual technique to rotate the lens. It becomes very, very difficult. So for a beginner, I would suggest before you remove the viscoelastic, you must place your lens in an ideal position, then remove the viscoelastic if possible by bimanual technique so lens doesn't move. That's a very comfortable way of handling the toric ICLs in this scenario. If you're using an Indian lens, then you are in the right 0-180 axis, but ICLs, yes, you have to place in a different axis. Second important thing is, whenever we talk about procedure in a larger audience, which we'll be catering to, many of them will be beginners. So we should always give them a conventional technique first, then try to stress, okay, we can modify in our technique also. This is my take on, for people here, you are experts. For people, we have to give a conventional technique first. This is the right way which has been practiced. This is how I have modified my technique for my own advantage or for my patients. Otherwise, beautifully covered.
So my last question to you, Dr. Tyal, sir, if you have a rotation day one that you find for a toric ICL, when would you go in and how do you rectify that?
I'm sorry, you asking post-op rotation?
Yeah, post-op rotation in the ICL, sir.
Okay. I think there are 2 or 3 important issues there. If I have a patient who I feel the ICL may not be in proper place of your pre-designated axis, but if the visual acuity of patient is good, I'll not hamper, go with any intervention like we do for cataract surgery patients also. If the visual acuity is not proper, then yes, you have to rethink why this ICL has rotated. Then it will depend on your biometry or anatomy of eye and the ICL bolt at present examination. If the bolt is very shallow or bolt is very steep, then your assessment of your sizing was not correct. Then you have to rethink of your sizing and go for a new lens. If you feel your bolt is adequate, that is around 500 microns, then your rotation may have been because of viscoelastic retention, which could have changed their position, or your primary axis may not have been correct. He rightly pointed out if you use a image-guided implantation, that will have a better axis orientation for your patient. So I would say if it will be basically either viscoelastic problem or a sizing problem. So both needs to be assessed. If it is a viscoelastic related problem, then you have to take the patient back again and maybe aspirate the viscoelastic and put the lens in the right orientation with the hydro procedure there. If it is a very shallow bolt or a steep bolt, then you have to exchange the lens.
I have a small comment here, Dr. Sonu. Dr. Sonu, can I make a small comment here?
So looking to the paucity of time, we'll just give you 3 seconds. So please, a quick comment.
Thank you, Sonu.
Okay, so a quick one. Now, when you suspect that the lens has rotated or in the eye, is that when the patient's spectacle correction is still complete, but he is accepting what is a plus-minus combination. That means a +1 and a -2 cylinder, or a +2 and a -4 cylinder, and getting a full vision, then you expect that the lens has moved in the eye. Now, when you see that, and then you actually, when you dilate and you check the parameters, you could collaborate that result. And then when it comes to correction, you have to see the vault, which usually is shallow in these cases. And the first impulse of an ICL surgeon is to bring the lens back in position and hope that it stays there. But we have some experience with these rotations, 4 cases so far. They all rotated. We brought them back, and 3 of them rotated back out of 4. So the impression is that even if you bring it back, there's a good chance that it will rotate again, and you would have to change to a size larger, and then they work.
So basically, undersizing was the basic cause.
Undersizing was the natural cause.
So thank you, sir. Thank you, sir. And thank you, Sagar. All to you, KP.
So no, just Dr. Parimal Desai wanted to make a small comment. He just raised his hand. Sir, unmute.
Yes.
Unmute.
No, it was the same. The lens sometimes rotates. I had two incidences. One, I just found a girl. She came to me after 3 years of toric implantation, ICL implantation. We dilated the pupil and we could just set it. And other was the guy who just got it after a week. As he told us, as Sonu sir told us, that because I think ICL was small, we just replaced that thing and he was fine. So I wanted to just discuss that only, but he just asked him, and so now my problem is solved.
So one last question to Professor Titial. Sir, like I did one case, patient with the keratoconus, the right eye refraction with the stabilized keratoconus, patient aged around 35 years old. The right eye refraction was around -4 sphere with -4 cylinder. I did a toric ICL for that particular patient. Patient was absolutely all right for now. I operated 9 months before. His post-operative vision was around 612 parts with the keratoconus. Today he had come to me with the drop in the vision of 660 in that particular right eye, and the refraction shows that +1 sphere with -5 cylinder at 51 degrees. So what is your opinion? How I should go ahead with this particular management, sir?
I think that's a clear-cut indication that ICL has rotated in this particular case, because all keratoconus eyes will have a very deep entry chamber, and the ICL sizing is going to be very challenging in these cases, because your actual lens position, lens rise is very difficult to assess in these cases. So I would suggest you have to reassess this patient with dilatation, see what is the peripheral bolt in these cases, because central bolt sometimes may not give a true picture in keratoconus eyes. You have to look to peripheral bolt also. If you can't see through dilatation, maybe you have to do UVM to see exactly what's the position of ICL haptics in relation to the sulcus in these cases. So I would suggest, if this has happened, I'll always go for oversizing the ICL in these cases, and it may remain stable. But I'm not very sure in a keratoconus. Despite you oversize, sometimes they still can rotate.
Just a quick comment. I mean, it's very unlikely to rotate so many months after implantation. Usually you find the problem soon afterwards. I would definitely have a look at the topography also, just to make sure that it's not the keratoconus that's progressed. And if that's not the case, whatever Dr. Titial said is all valid.
I had a patient whose lens rotated after 1 year. My own cousin, his ICL was implanted, and after 1 year he came with sudden blurring of vision in one eye, and the history of trauma was there. Someone of his friends banged on his head.
Yeah, trauma is
he banged on his head, and the ICL rotated.
Trauma is one of the minor trauma also. I have had 2 patients, minor trauma and ICL haptics on the entry chamber.
And even when you break a sudden, when you're driving your car fast and you suddenly break it, suddenly you will have rotation. One eye was trauma, other eye was the car driving.
These are normally in the shallow bolts.
So we'll have the next presentation because already we are running short of time. KP, all to you, please.
Thank you, Sonu. I think now I introduce Dr. Vardhaman Kankeria. He is a prolific surgeon who will be talking about the sizing problems in Phakic IOL, and the expert panel for this particular presentation, none other than our President, Professor Maipal Sachdev and Purandar Basi. Now I request my friend Amit Narwal to introduce Dr. Vardhaman Kankeria.
Thank you, KP. And it's my pleasure to introduce my friend, Dr. Vardhaman Kankeria, a young, dynamic phaco-refractive surgeon. He's a double gold medalist and an internationally reputed and India's first dual fellowship trained laser vision correction surgeon, trained from America and Europe. He has done his fellowship under Professor Palikaris, the father of LASIK himself. He's got numerous publications. His academic presentations have been known nationally and internationally also. He's been awarded, his name has been entered in the Limca Book of World Record for performing highest number of cataract surgeries, of refractive surgeries. He's been awarded many awards nationally and internationally. This is just a part of his CV. I can say just 5% of his total CV. So there are n number of things we can talk about to introduce Dr. Vardhaman. But just in short, nice human being, a great refractive surgeon. He's running a great fellowship, refractive fellowship program, and he's the director of Asian Eye Hospital in Pune, and a son of a refractive surgeon himself, Dr. Kakria. Over to you, Vadman.
Thank you so much. Just a second. Yes, thank you so much, Amit Bhai, for such a kind introduction. And I would like to first thank Dr. Partha sir for the kind invitation. Just a second. Yeah, for the kind invitation and to talk about the phakic lenses in this very, very august gathering. I'm just going to start my presentation now. So friends, as we have actually heard from all the speakers as well as all the seniors here, that phakic lenses definitely are very important part of our armamentarium today. And for sure, all refractive surgeons should get on to learning phakic lenses in their refractive surgery to complete their portfolio of surgeries as well. So before I come to the sizing of the phakic lenses, it is very crucial that actually performing the phakic intraocular lenses, whether it is ICL or IPCL, is probably not very difficult for a very good trained cataract surgeon. But the most important thing, or the holy grail of phakic lenses that we talk about, is sizing of the lens, and especially that we have to hit the sweet spot in terms of the vault. So for the benefit of our very young beginners here, I would like to tell what exactly is the vault. Vault is basically the distance that you have from the phakic lens to the crystalline lens. So basically from the anterior apex of the crystalline lens to the posterior surface of the phakic lens is the vault. And ideally the vault that you should target should be close to 500 microns. The ideal ranges from 250 to 750 microns. And probably the acceptable vault is with the current generation of ICLs is from 200 to 1000 microns. These are some examples of a good vault. As you can see the upper photographs, and the vault on the left side you can see is almost, the lens is almost touching the ICL is almost touching the crystalline lens, which is an extremely low vault, and such lenses have to be definitely exchanged because they will be having higher propensity of developing anterior subcapsular cataract. And the third picture that you see is a very high vault. As you can see, there are two PIs in place, although in spite of that, there is this there is a bit of shallowing of the crowding of the angle structures as well. If you want to really see the ideal vault, the ideal instrument is of course the ASOCT, where you can actually calculate it. However, if you don't have access to that, you can actually calculate it depending on the thickness of your cornea. So it has to be at least half corneal thickness to 1.5 times corneal thickness. So sizing of ICL, as I've said, is basically the holy grail of ICL surgeries. And there are a variety of studies which have shown that because of either insufficient or excessive vault, about 1 to 1.5% ICLs have to be exchanged for the correct lens sizes. So how do we actually size the ICL? So as we have already learned from some of the previous speakers, the ideal way of actually sizing the ICL is sulcus to sulcus, because that is exactly where the ICLs are going to sit. However, the only instrument which can currently do it very well is the UBM. And the UBM unfortunately has quite a significant variability in its measurements, and it is completely operator dependent. So unfortunately, although the ideal solution, we are not really relying on sulcus to sulcus by UBM anymore. So there are two surrogate markers that we use, either the white to white measurement, which is from the mid limbus, which can be calculated by a variety of instruments. But this is probably the most commonly used because it's simple, inexpensive, and easy to measure. It is available every part of the world. And the second one, which is now upcoming, is called as the angle-to-angle measurement, which can be done with OCT, as has been already discussed by Dr. Titiyal sir. This is a very important article by Parker et al. And they have actually seen, if you actually use the white to white versus sulcus to sulcus as the surrogate marker for your measurement of the intraocular ICL sizes, then the white to white seems to be doing fairly well when it comes to sulcus when you look at the vault itself. This is basically a diagram which will actually show you the forest plot, which shows that if you are having the white to white, which are the first bunch of articles, as you can see, about 20 articles odd, and the last 3 articles are from sulcus to sulcus. So whether you use the white to white or sulcus to sulcus, largely you're going to be in the sweet spot between 250 microns to 750 microns of wald. However, of course, for all the reasons that we have discussed, currently the most commonly sizing parameter that we use is the white to white. There are a variety of instruments that you can use for white to white measurements. The one that it is a good idea to use multiple instruments so that you have a kind of confirmation about it. But the most important being the digital caliper. So I think there should be one instrument that you rely on again and again because you have certain experience with that. But always understand that the digital caliper and the IOL master will always have a small definitive difference. The studies have shown that the IOL master actually overestimates the white to white compared to the digital caliber by about 0.4 millimeters. So that you have to always keep in mind. So there are a couple of small, very, very simple cases I'm discussing again for the benefit of some beginning surgeons. This is 25-year-old male patient who came for refractive surgery. As you can see, this patient had a myopic astigmatism. The corneal thickness was quite subpar. It was 460 odd microns. However, the patient had a good anterior chamber depth of 2.91 millimeters and 3.03 millimeters. This is called as the internal anterior chamber depth from the endothelium as seen by the serous. So when we looked at the white to white measurements, I think there was a fair amount of let us say agreement between the digital caliper and the HVID on the serous, and the IOL master of course overestimated, but I think this was fairly what was in sync. And that is when we went for a 13.2 millimeter of phakic lens size for this particular patient. We implanted the lens, and what we saw on the first day, that patient actually had a very high wald. It was about 1,100 microns. And it is very important that I would like to again re-emphasize the first day wald actually may change because the first day wald depends on a lot of factors. But you have to consistently actually understand how is the wald over time. And then when we looked at the wald at 7th day, it was still very high. At the end of 1 month, it was still over 900 microns. So this patient, as we discussed, had a very good anterior chamber depth of about 3.43 or 3.5 millimeters internally. So we actually decided to just observe this right eye instead of exchanging the lens per se, because we still had a very good angle. However, for the left eye, then we decided to undersize the lens by 1 size smaller, and then we went for a 12.6 millimeter for the left eye. These are the parameters that we used. And as you can see in the left eye, actually we hit the sweet spot. We were at 650 microns, and the patient has been doing very well. I think we have close to 1 year follow-up of this patient, and the patient is doing extremely well. The right eye has been under observation. The anterior chamber depth is still quite good. We do basically sequential gonioscopy intraocular pressures for this patient. Everything has been absolutely within the range, and the left eye has been doing absolutely wonderfully well. The patient is doing well in terms of its vision as well. Coming to the second patient, it's a 21-year-old young patient, had actually a fairly high myopic astigmatism. In this scenario, of course, because the corneal thickness was borderline, it was about 480 microns odd. So we decided to go for the ICL procedure with a good amount of anterior chamber depth of 2.93 millimeters and 2.87 millimeters in this case. Again, the digital caliper and the HVID on the serous actually showed a fair amount of agreement. And the IOL master did show, let us say, the standard overestimation, what was expected. So we were overall very confident that everything will be very good for this particular patient. And then we went ahead and performed the phakic lens with 13.2 millimeters. And to my surprise, actually, the wald was extremely low on the first day. The wald was only 145 microns. So when we looked at sequentially, of course, the wald didn't increase at all. So the wald was consistently about 116, 125 microns. And of course, as the studies have shown, it is very crucial that we have to have, so if in very, very low walds, either you can observe it, especially with the current generation of ICLs, when you have the Centra flow technology, the chances of cataracts are very, very less. But I think 116 micron wald is just too low for my own acceptance. So we decided actually to exchange the right eye lens with one size higher lens. But what we did in the left eye was that we had not yet done the left eye procedure, because I don't perform bilateral simultaneous ICL procedures. I always do one eye, and then after a couple of days, I do the other eye. So this gave me a chance to again actually reorder the lens for the left eye. So we went for one size higher in this case, and the left eye, we actually found the sweet spot about 488 microns of vault, which was seen to be excellent. So in the right eye, actually, this patient had to undergo exchange of the lens. So just to show you one example how the lens has to be explanted, as you can see from the side port, you can go with the viscoelastic under the lens, very gently pull only one haptic, and these ICLs are extremely pliable. So with even 2.8 or 3.2 millimeter, you will be able to explant them in one go with a two-handed technique. And then the other ICL was implanted inside. And again, in this right eye, we could actually found an excellent vault of 546 microns. So this patient has been also doing pretty well. The vision has been, of course, quite good. And the desired vault was actually achieved in both the eyes with the sequence. One more thing I would like to actually tell about the ICL sizing and especially the vault is that don't rely on the post-operative day vault. So as you can see in this photograph in the upper one, actually in this patient, we had used pilocarpine at the time of ICLs. So when you use the pilocarpine, the pupil actually pushes the ICL on the back towards the posterior side. So the vault on the day one was actually 160 microns only. So towards the 7th day, actually when the pilocarpine effect of course was gone, the ICL was actually at 700 microns of vault. So it's very crucial for you to actually know that whether you've used pilocarpine intraoperatively or not, and then judge your vault. So the take-home message actually is that despite following the recommended the guidelines from the manufacturer, it is very crucial that you have to understand that in some amount of patients, you're going to have either the low or the higher vault. So you should have your own strategies to go about it. What I personally do is I don't do bilateral surgeries at the same time. So when I do the first eye and when we look at the vault on the first post-operative day, it always gives me the advantage if in case I have to plan the other eye by either under or oversizing it. Of course, for people who have access to the intraoperative OCT, intraoperative itself, you can have a look at the vault, and then probably a bilateral simultaneous ICL procedure does a lot of sense. Okay, thank you very much. I think this was my last slide. And again, thank you to Dr. Partha sir and entire AIOS scientific committee for the kind invitation. Thank you.
Thank you, Vardhaman, for a fantastic presentation. Now I think we have with us two great panel. One is none other than our president, Professor Maipal Sachdev, and also Dr. Purinder Bhasin. So over to Dr. Maipal, sir.
Well, thank you very much, KP. Vardhaman, excellent presentation. I think what needs to be highlighted and which you have highlighted is that the sizing of the ICL is of critical importance. So there are two things. One, in a toric, the placement of the ICL, and otherwise, whether it's a spherical or a toric, we need to have the sizing of the ICL. Now, I normally do not rely on the pentacam, as you have rightly said, that not rely on the IOL master, because that does not give you an accurate estimation. So what we are doing as a the rule of thumb is that we are doing the digital kind of estimation, and that has stood the test of time. So I have not found any reason to change that. Yes, if you want a more physiological reading of the sulcus, you would do a UBM. But the point is that the manufacturer has actually designed the ICL to match with the digital reading. So the readings of the UBM could be different. So I don't think they still have an adequate nomogram or a formula that if you have this in the UBM, what are you going to do? And obviously, as the interpretation could be slightly different as to the angle and where you are taking it out. So I think majority of us are using the digital caliper, which is very, very important. Now, the second thing is that a high vault can settle over time, but a low vault never increases over time. So a low vault needs to be looked at more aggressively, while you can be a little more passive in a high vault. The only one thing which I might have done different from yours in waiting is that I often do a laser iridotomy in these cases. And that also tends to have the vault coming down. But over time, with more fluid going in and also with the central flow, you can have a slight decrease on the high vault which is there. So what you have to see is that the pressure should not go high in a high vault, and that needs to be graded, and that needs to be calibrated and looked at from that perspective, that the pressure is not going high. But otherwise, you have to, as you rightly said, in about 1.5%, 1 to 2%, you might have to change the ICL, and there are no reasons that you can get as to why that patient had a high vault or a low vault, because the internal configuration need not match the external measurements that is there. But despite these fallacies, I think we still are doing the digital caliper, and the presentation was good, and you highlighted the whole thing. And just the point that I wanted to add was about a peripheral iridotomy that could have been done, and that also helps over time to reduce the wall. The other important that you need to see is that if you leave a low vault for a long time, the cataract tends to get there. And there are a lot of people, I think Dr. Bharti is here, so we can have a little bit of controversy because he's somebody who does bilateral simultaneous cataracts, especially the premium IOLs as also the ICLs. But I think precisely for the same reason which Dr. Ram has also pointed out, that you can actually grade the response of a patient, whether it is in an ICL or a premium lens, and see as to what the patient is doing or how the patient is kind of behaving to that, and then work. So whenever there is something where I get a problem of a vault being difficult, I would postpone the patient for some time or decide or change the lens, because the lens may not be available immediately. Otherwise, that is a good learning that you get from the other eye.
Absolutely.
So if there is a malsizing that is happening in one eye, it is likely that it can happen in the other eye. So you need to work your way around and do that, despite the company having you that this is going to do this. And sometimes the company actually throws up a warning. If you go to their the site and put a lens, it says this is not as per the size. But then and that can cause you actually, I have faced one of these problems in a consumer case. That there was a problem in the sizing, so we went on to a different size, and there was a warning which I had never actually looked at, and it says that this is not the appropriate size. So the patient kind of held that and said that this is not the appropriate size, but then you are overruling the nomogram which the company is giving as regards the size of the and the company washed away its hands in the court, saying that this was not as per the nomogram, and it is the surgeon's decision, so we don't come anywhere in the picture. So just
Maipal sir, one question, sir. Patient with a very high vault, I have tried after 15 days or 20 days. In case of a spherical ICL, I rotated the lens. If it is in the horizontal, I rotated the lens the opposite direction. What is your take-home message on that, sir?
Can not in the opposite direction, but 90 degrees away.
90 degrees, sir. 90 degrees. Sorry, 90 degrees.
Yeah. So you can do that. I think that can basically, the spacing is different. See, it's not 360 degrees. It's the same all across. So basically, in a spherical, it does not really matter as to where it's placed. But in a toric, you can't do that. But the first thing I'll do is maybe wait for some time, do a peripheral iridotomy. If it is critically high, then I could do a peripheral iridotomy. And if it is not settling over the time, I have really never tried, but it stands to logic that you can rotate a lens and possibly, but then I don't know, you might have to find out or figure out by a UVM as to where the internal dimensions are higher as compared to what is causing a high vault. So otherwise you just rotate it, and I don't know where to keep it. 90 degree may not be the biggest kind of size internally.
Dr. Purendra Basin, a few comments.
Yeah, very nice presentation, Dr. Vardhaman. And it's so beautifully highlighted. Both the cases were so important. And what I feel is that here, there are two things which has to be looked upon. One is the anterior chamber depth, and more so in toric IOLs, because you are always having a confusion whether we should go on a higher side, whether we should go on a lower size of the lens. If you go on a lower size of the lens, then there is a chance of low vault. And if you go on a higher side, then there is chance of high vault. And in toric IOL, you always prefer a larger size of lens. So when the anterior chamber depth is low or borderline, then it is very, very tricky to be on a higher side. So this is, this is what I feel. And secondly, when there is a transition period, like in your second case, it was 13.2 in one eye and 12.6 you opted in the other eye. So when there is a change, transition of the lens size, when the size of the white to white is in transition phase, when we have to select from 12.1 to 12.6 size and 12.6 size to 13.2 size. So in those cases, yeah, and when you are doing a toric IOL, so you have to send, what I do is I send back to check it again, whether this is adequate. That I comment that the depth of the anterior chamber is 3.4 in this particular case. Are you sure that we should go for 13.2 size or in this toric IOL? Or if you, so they check it again and reconfirm, then only I place the IOL. This is what I do personally. When the lens size or the wide to wide is in the borderline range and when the anterior chamber depth is shallow. In those cases, it is very, very tricky when we do the toric ICLs. I think very nicely, very beautifully depicted, and Dr. Mahipal has also rightly appreciated these things. In a high vault, it's more forgiving as compared to the low vault, very low vaults. So low vaults are less forgiving, and it is wiser to explant it on time if it is around 100 micron vault.
So also with the lens rise concept, sir, because if it is a very low vault with the lens rise, if it's a very, very young,
lens rise,
then the vault will go on decreasing as time goes
further. True, absolutely.
Okay.
Thank you, Doctor.
Nice message that Vardhman has brought about bilateral simultaneous surgery. So I think for the beginners, they should all do one eye, assess the vault, and then maybe plan the second eye.
Absolutely.
Sonu very rightly said, and in post-keratoconus eyes, I usually prefer doing one eye, and I order one eye at one time. Because you never know, these lenses, sometimes they have to be imported. And then they have to be asked to come and they take time. So I tell patient that we'll wait for some time and we will go one by one and see the results, because the anterior chamber depth is not reliable in post-keratoconus eyes. Central anterior chamber depth is not reliable. So recently I did one eye. I have seen the good vault is obtained in one eye. So now I have ordered for the other eye, and next week we are going to do that eye. So this is how I do personally. So all these things, finer things, I think we have highlighted in this whole webinar. I really appreciate Dr. Somshila and Dr. Partha for bringing all these experts over here. Thank you.
Thank you, Dr. Purinder Bhasin. I think let us come to the last presenter, Dr. Ayan Mohanta. The moderator for this particular talk is Somshila Murthy. Over to Somshila.
Thank you very much, Dr. Kudlu. So we go on to, thanks for everybody's patience. We'll go on to the last but not least presenter. And I request Dr. Bhalla to please introduce the last speaker.
Dr. Bhalla?
Dr. Bhalla, sir, I think you are muted. You are muted.
Unmute. Hello. Dr. Bhalla?
I have the privilege of presenting the last case presenter, Dr. Ayan Mohanta. Dr. Ayan Mohanta joined Desai Hospital and Research Center about 20 years back on December 1st, 2001. He has performed numerous cataract surgeries and refractive surgeries, both LASIK and also Phakic IOLs, ICL and IPCLs. He is one of the prime phaco trainers at Desai Hospital. He did his MS from Regional Institute of Ophthalmology, Kolkata in 1997 and MBBS from Neil Ratan Sarkar Medical College from Calcutta in 1991. Over to Dr. Ayan Mohanta for the last presentation of this wonderful webinar.
Thank you. Thank you very much, Dr. Bhalla, for the kind introduction. Good evening, everybody. And I especially thank... Hello.
Can you stop the slide share, Dr. Bhalla?
Yeah. I especially thank Dr. Partha Vishwas and entire scientific committee team for giving me this opportunity. So, are my slides visible?
Yes, sir.
Yes. Yeah. So I'll be talking on Phakic IOL with cataract management. So I don't have any financial interest to disclose. At the outset, I would like to begin saying that cataracts these days with the most advanced type ICLs are extremely rare. And recently they have, not recently, I mean for the last 5 years, they have come up with a central hole, ICLs with central hole. And in a study, they have found the incidence of cataract being nil. The causes of cataract is being the low vault. Ideal vault is 150 microns, which is recommended because of decreasing vault over time. So this is one such case in which you can see that the lens is a bit eccentric and the central part looks okay, but if you go to the peripheral part, the ICL is touching the periphery of the crystalline lens. So these all things lead to cataracts. In one study, they have found that anterior subcapsular cataract developed due to injection of BSS jet through the hole, impinging on the lens capsule. Also, flipped ICL is a cause of cataract. Excessive manipulation, like Dr. TTL said, if you have a upside down ICL, never attempt to correct it inside the anterior chamber. It's better to take it out and then reinsert. Also, there is a trapped viscoelastic material below the ICL. It looks like cataract. And sometimes I have seen in my personal experience that this leading to anterior subcapsular opacities. Also, the myopic eyes develop cataract early. And there is always the presence of senile cataract. So these are some of the preoperative considerations. Biometry per se is not a problem because ICL does not hamper with the biometric calculations. Extreme axial length considerations are to be done. Whichever formula suits you best, go for that for calculating the IOL power. Specular microscopy is better be done because you are doing another surgery, and if you have a low endothelial cell count, you can warn the patient that you have a low endothelial cell count, so you might land up with corneal problems. The choice of anesthesia is topical, preferably. Incision location is temporal. Those who operate from the head end, they have to keep in mind that the ICLs are placed in horizontal axis, so you have to rotate the lens to 12 and 6 o'clock and then take it out. The type of cataract is usually anterior capsular with occasional fibrosis, so your armamentarium should be okay. You have to have micro scissors sometimes. And these are all myopic eyes. So phacoparameters are to be on the lower side. You have to reduce your bottle height and you have to reduce your IOP if you're using a Centurion machine. So this is a IOL explant with a ICL explant with a IOL implantation. So we go in for a 3 millimeter incision, fill up the anterior chamber with viscoelastics to prevent the endothelium from getting injured. I personally prefer to bring out all the haptics because this case was done somewhere else. So you never know, there might be adhesions in the periphery. So while you're pulling the IOL, it might injure the iris as well. So it's better to bring out the haptics and then pull it out. It gently unfolds on itself and comes out. So the rest of the part is like simple cataract surgery. So you fill the anterior chamber with viscoelastic, do a rhexis. And one thing you have to keep in mind, you have to prevent chamber fluctuations. Since these are long eyes, the chamber fluctuates to a great extent. So the hydrodissection is being done. The nucleus is rotated. And mostly these cataracts are soft cataracts. They come out very easily. And as I said, that the phacoparameters are to be on the lower side. The bottle height should be low. And your IOP, if you're using a Centurion machine, should also be very low. I prefer around 26 millimeter of marker in my machine. And when I am taking out my phacoprobe, always remember to fill the anterior chamber with viscoelastic because otherwise the anterior chamber is going to collapse. Cortical aspiration is being carried out. And you can see the large PI in the right-hand side. This was expand series lens with a -1 diopter. It goes in. And I usually orient all my lenses in supernasal and inferotemporal orientation. And again, with before bringing out my irrigation cannula, I tend to hydrate the wounds. And this is another case in which the ICL was flipped. That is upside down ICL. You can see a cataract that has developed, and there were plenty of pus in the periphery. So again, copious injection of viscoelastic and taking out haptics one by one. With the olive tip applicator, I found it very difficult to bring out the ICL because the ICL now it has become a concave in nature, so it would not engage. So I took a Sinskey hook and gently took it out in the anterior chamber, and then grasped the lens, and you can see it was flipped because here you can see the holes, the leading left and trailing right. So it's a flipped ICL. So this is a very interesting case, a Varese Phakic IOL done long time back. So these cases you might find one occasionally. So you measure the diameter of the lens and then it's at 4 millimeters. So it's better to go for a scleral tunnel and bring out the lens. So here, I think SICS would be a preferred option. You can do a phaco from making another tunnel somewhere else, but that will lead to further trauma. So here again, filling up the antechamber with viscoelastic. The enclavations are disengaged. And while doing so in this one, part of it broke. Be careful to take out the broken particle. And now while taking out, I found some resistance because of the sharp edges. In such a case, it's better to rotate it and then bring it out smoothly. Thank you very much.
Thank you very much, Dr. Mohanta. I think that was just a fascinating series of cases that you showed us, and a lot of good points in how to explain the ICL. In fact, interestingly, just very recently, I had a patient who had bilateral, was operated elsewhere and had bilateral cataracts after ICL. And in one eye, the ICL was flipped, and in the other eye, they had actually inverted the flipped ICL. So it was, for me, it was the right side. And the ICL which was not flipped was much easier to remove, just like exactly how you showed. But the ICL which was flipped, I did exactly the same technique, put the Sinskey and then disengaged it. So yeah. It was good to see that. And that was just guesswork on my side. So it was good to see you do that.
Yeah.
So did that wonderful presentation. I think we did save the best for last, looks like. We'll go to the discussants for this particular session. And I'd like to ask our chairperson first to start off and discuss how does he tackle such cases of cataract management after ICL.
Okay. Thank you very much, Dr. Somshila. I'll just, the presentation was nice and I think he made out all the points, but I'll just wish to emphasize some points and some differences in what I do. The first important point that he made was that an IOL power calculation is least of an issue. So you have to put your normal formulas, which you do, because the thickness of the ICL is very little and that can be negated, and there's nothing much that you need to do. The second thing which is important as regards doing it, I normally prefer to use what he showed later. I use a Sinskey hook to actually nudge from the hole so that I just bring out the upper haptics. I don't need to actually work on the lower one because they will automatically come out if you pull it out. The second thing that I wish to say is that you should always have, now that you have phenocaine available, you should always have that, because sometimes there is, when you pull it out, there is a rub on the iris and the pupil may come down. So you need to kind of have that ready so that you can use it. Now, I always, when you get the hold of the upper haptic, I normally do not use a McPherson forceps at all, because it tends to slip at times. So I would, even if I have to use a McPherson, I'll do a hand over hand technique. That means I hold it, and then with the other one I bring it out, and then I pull it out. So it's so that you actually get a meat of the a reasonable amount of length in your grasp before you are actually pulling it out. Because if you are just getting the tip and trying to pull it out, you can often get a tear at the where the hole is, and you can have a problem. So that is something, because it's thin in the periphery also. So that is something that I do, a hand over hand technique. And if you have to use something like a McPherson, I would prefer to use a capsulorhexis forceps, because that gives a slightly better, because there's a bend and it gives you a slightly better hold. That's just a individual variation that I do. But nowadays I've started using the smile curved forceps that we have, and that gives you a very good hold, and we can actually remove the ICL much easier. So a couple of things that I wish to highlight, that is about all that I will wish to say. Always I will prefer a Sitski, only remove the top part of the ICL haptics, do a hand over hand technique, and use something different from a McPherson to pull it out, and use Phenokin. Now, one thing which obviously does not concern a lot of people is that when you're using a femtolaser platform, for doing a femtolaser on these particular cases, at times the femtolaser gets, the OCT of the femtolaser gets fooled. Because it will pick up the ICL as the top part of the lens, and you will have to actually do a default setting. So I have had this problem once or twice, more so in the LensX machine than with the Catalyst machine, and therefore it becomes very problematic for you to actually work with a half-cut capsulotomy and remove the lens. So I have actually given up doing a femto in these procedures, because you have a free-floating capsulotomy or a half-cut capsulotomy, and you're trying to pull it out. So if something goes wrong, then you have a problem, and then locating the edges of the capsulorhexis becomes a problem. So I normally wish to not work with a femtolaser platform in case of a ICL where I have to do a cataract surgery. And because of the anterior capsular opacifications, which are quite often there, I would prefer to use trypan blue also if required in these particular cases. So these are a couple of the tips, and normally these cataracts are pretty soft. So you're not using much of a phaco energy in these particular cases. Even if you have a nuclear sclerosis, they are not tough cataracts, and they are soft cataracts which we can remove out well. So these are a couple of the things that I'll just wish to say. Overall, an excellent presentation of the various ways that he can work with removing the ICL and then doing a cataract surgery.
Some of the surgeons, sir, they keep the ICL in the anterior chamber, they do the phaco, and they once again re-implant the ICL after the IOL implantation. What is your take home?
Sorry, there was a point that I wish to actually add, is that I use a lot of Viscoat or a chondroitin sulfate in all these cases to protect the endothelium. That is something that slipped out of my mind. I always have chondroitin sulfate and a specular, because you are dealing, at times you can rub the back of the endothelium and cause a problem, and wherever it gets rubbed, you can have an issue. I have never done that, because I really don't know what purpose that is going to serve, that you are keeping the ICL and then putting the lens and trying to work through that. I think it's more to show some people that we can do it this way, but otherwise I don't see as to what purpose you are, because typically most of our ICLs that we are doing are myopes, and they have deep chambers, and you're not coming, it's not a question of protecting the endothelium from that. The only time that you need to protect the endothelium is when you are explanting the lens. Otherwise it's a normal phaco that you are doing. So I don't try that heroics to have the ICL in place and put the lens first, and after putting the lens, do the phaco, then put the lens and then remove it. No, I haven't done that, nor do I see any specific advantage over it. But Viscoat chondroitin sulfate is a must, which thanks for bringing it out again regarding the corneal endothelium. We want to do and preserve that.
Dr. Kudlu said that we'll implant the same ICL. We cannot do that because IOL power.
No, that's a different power. I don't think he said that. I thought he, did you mean that, Kundu? If he said that, that doesn't make sense.
I have seen Sri Ganesh, one of the video, he was showing that one of the Sri Ganesh video, that he got the ICL into the anterior chamber, he kept it aside, did the phaco, once again, he implanted back the same ICL. I was very much shocked to see. So I need your opinion.
Sir, that was a case of high myopia where he was not able to get probably a lens of that particular diopter, I think.
No, but Sonu, that's obviously not possible, yaar. Usme to bahut
IOL power calculation will be
It
altered.
was an award-winning video in one of the ICL user meet, and what he was emphasizing was that the same the ICL was kept, and it did cataract, and he could calculate the IOL power, and maybe +4 or +5 as far as I remember, few years back, sir. So probably a very extreme of myopic conditions he was trying to show.
You mean for an IOL which he was not able to get, he used that as a piggyback and used another power. So it was
Correct. Same ICL was being used as a piggyback kind of stuff.
Formulas could be pretty different.
What is the basis of IOL calculation in that particular case?
Yeah, that's what.
So since we don't have that case here, maybe we won't discuss, but definitely the same ICL cannot be placed. It's possible that they may have done a calculation and realized that they have an ICL of that calculation which could have been placed. That is what I'm assuming. Or there could be a piggyback ICL used because you might have one IOL and then you still are deficient and then you might have used an ICL as a piggyback. But otherwise you just can't.
Or maybe you used an aura.
Okay.
That could be a possibility. You do, you have that and do an aura and see what, I don't know.
Maybe. So we'll go to Dr. Biswas just because we're really on time, not on time. So Dr. Biswas, we need your comments now from the master.
Thank you very much, Somshila. And to tell a small take is, when I asked Ayan that Ayan, would you be comfortable to talk about cataract with ICL or IPCL? Is it possible? So he said, obviously, I've done so many cataracts in which ICLs and phakic IOLs have been implanted. And I nearly believe that all the cataract patients have gone to him for which possibly I did the ICL or the very second. So, having said that,
so basically, you are asking him to give you something in return.
So that's an honest confession.
Honest of you, Partha.
Very honest.
Can I make a last comment? Partho?
Sir. Yes, sir.
I think, as far as cataract is concerned, in a post-phakic IOL series, I have also done multiple cataract surgeries for a patient who had undergone ICL surgeries. And this is published in Eye also. And we realize now in the recent generation ICLs, the cause of cataract surgery, the requirement of cataract surgery post-ICL is not because ICL vault-related problems. It was because mainly I had 50% of the cases because they had a vitreoretinal problem where I had to do a cataract surgery for vitreoretinal surgery. And there were one case of inverse ICL and one case had a severe glaucoma and inflammation. So we realized that cataract formation in today's generation, not because of ICL vault-related problem, it is mainly because of other assistance required for a DR surgery was a major indication for cataract surgery in our series.
Also, Dr. Titial, don't you think that the high myopes that we have, the onset of senile nuclear cataract is higher, is about a decade earlier? And so if we operate on these patients who are in their mid-30s.
That is what Dr. Mahipal talked about in the beginning. We do have patients come with a nuclear sclerosis much earlier in these group of patients, though we don't have a case control study to prove that in myopic patients with ICL, they'll have early onset. But we do have myopia patient coming with these things. But I've seen cases with my IPCL series also. I've been using IPCL for last 3 years now. I've already done at least 3 or 4 cataract surgery in these patients. Because these are an older group of patients, because I'm using a presbyopic IPCLs for last 3 years. And these patients are 40 plus. And I agree to Dr. Mahipal correctly, these people do have early, nuclear sclerosis and they demand surgery because the correction goes haywire after ICL, IPCL.
So one or two small points.
Sorry.
Yeah, go ahead, sir. Go ahead, sir.
I think Dr. Ram also said, you also said, I've done a couple of IPCLs, but both of you seem to have, it's a reasonably recent lens, maybe 3-4 years old or 5 years. I don't know. It's not as old as ICL.
6 years.
Yeah, whatever. So why are we getting the cataracts? Is it that in the IPCLs, the cataract tends to happen earlier than? ICL?
In a word, I mean.
No, sir. I said because I am using Phakic IPCL, so my patients are 40-year plus.
I heard that you qualified that, but Dr. Ram, I don't think has used all those as Phakic, and he says that he has also done with IPCL. So I'm just asking that in the healing of the panel, does IPCL, is there a higher percentage of having a possibility of cataract as compared to the latest generation of ICLs?
If I might just add on, frankly, I don't think the type of lens really matters. And it's been a published study from Zaldivar years back, where he says the chances of cataract developing increases with 3 factors. One is, of course, the sizing, lesser the sizing. And second is the higher the age. More beyond 40 years, more the incidence of cataract. And third factor is a power of beyond -15. So these are the 3 factors. So obviously, as Dr. Somashila said, all these high myopes as such have tendency for nuclear sclerosis to come on earlier. So I believe that if it's only anterior subcapsular fibrosis, you can really blame the lens. If it's a nuclear sclerotic cataract, maybe the patient would have developed that even without the phakic IOL being placed.
But you know, there is a factor of lens metabolism changes happening with ICS in the long run. So we are not sure that might cause the nuclear sclerosis changes coming up also.
I mean, that's absolutely right. And that might be the reason these patients get it. But that would have been a greater problem with the lenses where the central hole was not there. Now with the hole being there, the circulation of the aqueous is supposed to be quite...
yeah, but Dr. Mohan, an excellent picture. Peripheral touch, obviously there has to be a peripheral touch, so I think it might be causing something on the metabolism. We have to do a case control study. I really don't know how we can do it with one eye an ICL and the other not an ICL. Could be an anisotropic eye, and you would say that it's because of high myopia. But anyway, that's just a feel, because there is a touch on the lens in the periphery. Even if with the vault you have a hole, but there is a significant amount of touch in the periphery, and the photograph was brilliant. I think, Dr. Mahanta, that was an excellent.
Let me share one more my experience within IPCL and ICLs. The material does make a huge difference in a bolt, especially when you have a meiosis or a pupillary dilatation. If you see the change of bolt happening with meiosis and dilatation much more with the IPCL than ICLs. That I have seen in ICL, people have reported the change can be around 50 micron plus minus 50, around 100 is this thing. But in IPCL, this is much more. And the vision changes significantly with the meiosis and the pupillary dilatation.
And one additional point I would like to add here is it was both regard to Vardhaman as well as the IAN's presentation. My indication for removing a ICL would be really an onset of cataract. I have a few patients who have a vault. I mean, Vardhaman's case had a vault of 115. If the anterior capsule is quite clear and lens is quite clear, I would still observe these patients. I think even the Mark Becker's study shows that, you know, it's a multicentric study. And it shows that even from 100 microns to 1000 microns, patients have been followed up without development of glaucoma or cataract. So obviously 250 to 750 would be the right measurements, but then if the chamber is deep, the IOP is okay, and there's no onset of cataract, you can sequentially follow up these patients along with a good gonioscopy, and do not be in a hurry to remove these lenses. Often there's a sign of a cataract develops a little periphery, not in the center. Once you see a cataract developing, maybe then it's time for you to interfere and take the lens out.
So I think what you mean to say, sir, if there is a peripheral touch and there is a subcapsular cataract, and if it is progressive, that's an indication for the expert.
Absolutely. And another, all these details, you know, maybe this was shown here, but they are not supposed to be sitting on the lens even peripherally. They're supposed to be floating around in the sulcus, though, I mean, that's what the company claims. I mean, that's not really touching on the surface of the lens. Maybe if you size them appropriately, it should be like that. And that brings me to another point which Kudlu made, that is, you know, he had high vault and rotated it from horizontal to vertical. That would actually increase the vault, because most often the horizontal white to white is larger than vertical white to white. So I'd rotate it if the vault is low, but if the vault is high, I don't think a rotation to a vertical axis would really help.
I think the internal sulcus vertically is much higher than the horizontal. So I think with the higher vault, if it is horizontally placed, you can flip it vertically so that the vault goes down by 150 microns.
Yeah,
I think
it's around 300 microns. It goes down.
that is what my understanding is. Because the internal sulcus to sulcus vertically is much more bigger than the horizontal.
One or two small points, if I can just make. Ayan showed actually excellent explantations, but at times there are a few compromises and a little bit of difficulty, especially if a younger surgeon is doing. One thing is the dilatation of the pupil. The dilatation of the pupil must be as large as possible in such cases, and the use of the viscoelastic, what Maipal sir said, is very, very important to get those haptics out. And once the haptics are out, then it becomes important also the incision where we are putting in the phakic IOL. When we put it in, then it is nearly horizontal. But when you are explanting a phakic IOL, the incision must be a little dipping down so that the haptics, when you're taking out, get into the incision site very easily. Otherwise, if the incision is very flat, then it has to be tipped up, and there is a difficulty in grasping and re-grasping the foot plates. So that is one thing that I just wanted to share. The other thing is the iris. If the iris by chance comes into the way, then you have atonic iris, which will gradually come down and make things difficult. So these are a few things about what I just wanted to say about the explantation. Otherwise, the explantation is a very nice way, and it can be very simple. The forceps are very important, and the end-holding forceps that is used is very atraumatic, and it pulls out the columnar lens extremely easily. Another thing that I think we just missed out on is the white-to-white. And initially, when we started off with the phakic lenses, and especially with the ICL, we used to do it with the OBSCAN. And that was the standard that was said that the white-to-white with the OBSCAN is the standard. And it really stayed as the gold standard. And then, of course, most of us went on to the caliper because the OBSCAN was not available most of the time. So right now, the caliper is one gold standard that we are using, and the other is the Pentacam HR. Also gives a good white-to-white and quite an accurate white-to-white. And as was said by all the speakers, that the IOL Master and the oculizer actually overreads the white-to-white.
Partha sir.
Yeah.
Just white-to-white, one small doubt I am having. Like people tell that, see, Vardhaman presentation, he told that mid-limbus to mid-limbus. But few of the people, they say that it is from the black to black, where the black ends. If you measure that, it's perfect. But I need to know from all the expert whether mid-limbus to mid-limbus or white-to-white, or the where the black ends till the black.
Okay, Ayan wants to answer that. Yeah, Ayan,
I will not answer. I want to show a video on that. Is that allowable?
Yeah, allowed.
Okay. Fine. Go ahead.
There are no charges on you. We will take.
Previous one is not going.
Stop sharing the previous slide.
I am pressing on new share.
Sunilji, can you stop the slide share for Ayan?
Why? Yeah.
Yeah.
That same thing is coming. Anyway, I think I should quit.
Actually, while he's getting ready, just a comment about what you said, Partha. We measure both with the digital calipers as well as the OBSCAN or the topolizer Vario. And usually what we make sure is both these things correspond, the horizontal white-to-white. Sometimes if you have a small pigment or a blood vessel or even a pingicula at the limbus, the instrument fails to, the topographers fail to recognize it and may include it into the white-to-white. So we make sure that the two factors line up these two are nearly the same, then we go ahead and use the values given by the topolizer vario. And as was said, IOL master and anything using laser interferometry gives you a slightly larger reading because they measure not white to white but sclera to sclera. So that's the reason there's a difference of about 0.4 to 0.5 millimeters. But I think if you're using calipers alone, it's a good idea to take the patient to the theater, make them lie down under the microscope, and you put a speculum in and measure. That will definitely give you a more accurate reading.
Is this visible?
Yeah, very well.
So this is 10.82 and this is 11.72. Now what should I take? This is the other eye. This is the left eye. This is 10.82 and this is 11.72.
So what I see there, the 11.72 was definitely on the white side, and the 10.82 was definitely nearer. But we would definitely have to compare the right and the left, and if whichever is as equal to the other is what would be the best guess.
The other eye is 11.12. The other eye has got 11.12.
But 11.12.
Yeah.
But 10.8 here, I think then comes the other instruments also. Then the IOL master and the oculizer also need to be seen whether this big difference is coming, because this is very unusual. If such a big difference comes of nearly about 0.7 to 0.8 microns, then 0.7 to 0.8 millimeters, then that is not an acceptable difference.
Let me answer Kudlu's question. I think it is the way you're going to measure every case of yours. So you have to have your own landmark, which you are going to do for your case. And you'll have a series of your patient, and you'll rely on that particular anatomical mark. It can be junction, it can be white to white. You have to decide what is your landmark. And then have your own like we talk about A constant, you have to have your own landmarks. You can't rely on others parameter in these cases. So if I'm doing just inside, or if I'm doing just at a junction, every case I'll do a junction and compare with my other instrument. Then I'll have an algorithm of my own corrections. Because they can.
Yal is saying is very right. You have to have your own gold standard as to what you're using, where you're using. So like what Partha said, we always have a pentacam reading also with us as regards the white to white. I never use the IOL master, but we have a pentacam reading, plus we do the digital, plus we do the other eye. So if there are discrepancies between the three of them, between one eye versus the other eye, as also between pentacam and the digital caliper, if there is a lot of discrepancy, then we will go ahead and redo it, and then there is a problem. But you have to have your own gold standard as to what you are using as a measuring technique, and the digital caliper is our gold standard in center design.
Thank you.
It's extremely unusual to have such large differences between the two eyes. Because,
I think the eye was moving a lot. I think the accuracy of the reading was slightly, could be a little better.
I think I would correlate vertically also, sir, in this particular eye. Measuring vertically also could give you a small clue to the exact measurements.
I think, Sonu, you can always play with, your way of measuring things. If I have to have a topography and show that, my topography is equal or different, I can just take in 10 minutes and 2 topography readings will be there. Similarly, when you are doing a white to white measurement, it's the position of the eye, how flat patient was, the head position, the tilt, that makes a huge difference.
Yeah.
If in the same eye I can have a 10.8 and same eye I can have a 11.2 also, the way I measure it. The tilt in the instrument, the tilt in the eye, all these things has to be looked into.
So if we were to err, for example, it's a very close call between say 12.6 or a 13.1 ICL, would you err towards a size or a lower size? A general question to all the panel.
So that will depend on apart from the wide to wide, what is my AC depth?
Yes.
If AC depth is very deep, then I'll err towards the higher side. If AC depth is shallow side, then I'll err towards the smaller side.
Supposing it's a normal AC depth.
That was a higher side, sir, because I would like to have a higher ball than a shallow ball.
I think the usual consensus is now erring towards a higher size, one step up if given a choice.
That is true.
I don't think you can say that as a consensus, Sonu. I mean, as was said, it's a combination of AC depth and keratometry as well as white to white. All these factors are taken into consideration in the company's calculation when it comes to the ICL power. And when it's between what the sizing is usually for 3 to 3.5 millimeters. And when you come below that or above that, accordingly, it jumps up by one step or comes down by one step. Because obviously, when you have a small eye, you want a smaller lens. So that just stands to reason. But it's extremely important to get the right measurement because
everyone, what is the general consensus nowadays on with the Centraflow? What is the consensus on the cutoff? Is it still 2.8 or what is the general thing that we are taking?
2.8.
I take it 3.
3?
My cutoff is 3.
Okay. You are an RP center, so your cutoff has to be higher.
No, Namrata is also there. You can take her opinion also.
So, Somshila, what is your cutoff? 2.8 or 3?
So,
3?
our cutoff for ICL is 3, but we also look at a few other parameters and we do 2.8 also. So,
You do 2.8 also. When? If the cornea, if it's a keratoconus or what?
No. So, if the white to white anyway is smaller, so these are slightly smaller eyes anyway. So the AC depth will also be slightly on the smaller side. And we try to aim with the lower, as somebody mentioned, the lower sizing. But if it's IPCL, then it becomes a little easier because we can have a better range for ordering the lens. So if we have a shorter AC depth, then we usually try to use an IPCL in these cases.
So Partha, Bharti, Sonu, what do you use?
2.8 for me.
2.8?
0.8, yeah. But if it is 2.8, then I definitely check the angle as well. And that is, if it is nice and widely open, then I do not hesitate to put it in 2.8.
Gonioscopy and maybe higher threshold for PI or something like that.
Yeah.
Okay. So apart from Dr. Titial and Somshila is borderline, sometimes 2.8. Namrata would also be 3. Any of us are still keeping it as 3 or we have got it down to 2.8?
You can go in between 2.9.
The golden middle.
Hyperopia hyperopia 3, myopia 2.8.
Myopia 2.8. Okay.
Same here, sir.
Same.
I never imagined that Phakic IOL-Learn it from the masters would be such a vibrant course, sir. Thank you very much.
I have heard some people, if you have a AC depth around 2.7, 2.8, they'll do a two YAG iridotomies and just see the patient after 4 weeks and reassess the depth. Is somebody doing like that?
The 4 weeks is for praying.
I listened to somebody saying that a YAG PI will change the AC depth and then patient becomes suitable.
I think it's extremely important to stick to the rule of 2.8, especially for high hyperopes and high myopes, because the periphery, the plates are pretty thick in those cases.
Dr. Titial, progressive, yeah. 3 has been given up long time ago. It's 2.8 now. So,
I think I agree to that. If you have to look into other parameters also.
2.8 can cross the road.
You can cross the road. That's what I said. If you have 2.8 and you want to say no, ask them to cross the road.
So you have to look other points also. Like, I rightly pointed out angle area. Now we use KCR2 now in our place. You can see the angle opening distance, angle as such, or a lens thickness into consideration, and that will give the if the company gives me the lens, I'll put it. No issues.
So shall we call it a day now?
No, call it a night, not day. Day will be too much.
So Partha, please tell Swiggy and Zomato to deliver our dinners.
The presidential dinner.
You are the future president, na?
No, make it chairman dinner, chairman.
Chairman.
Sir, Rosagulla to khila do, sir.
Kolkata mein 2021.
Oh, kya?
In Kolkata 2020.
2021, right.
Virtual Rasgulla.
Original Rasgulla, real Rasgulla.
Good.
Oh, thank you very much, sir. Maipal sir, Tityal sir, and Ramurthy sir for being chairpersons and sticking all through this wonderful program. It was really learn it from the masters, and the masters were there, and that's how the program took off so well. We have had a large number of viewers, and I'm sure over 1,000 viewers, and obviously those 1,000 would be people who are wanting to learn Phakic IOL maybe for the first time. So it's been a very, very nice course, and it has delivered so well. And our panelists, Bharti sir, Ras Haldipurkar sir, Dr. Namrata, Dr. Sanjay Chaudhary, Dr. Purendra Bhasin, and Dr. Parimal Desai sir. Thank you very much for being panelists in this. And of course, our speakers, we wanted to have the young, vibrant speakers, and Anant did a wonderful job. Oyan, wonderful. Gaurav, of course, showed all his terrible videos, and he, of course, said that these terrible videos occur to him only and not to any of the other users of Phakic IOL. So it was a lot of learning from all the takes from all the different surgeons. And Oyan, of course, was wonderful. What Vardhaman showed, and that sizing issue is something that we have to do very well. And Dr. Kapil Varma and Sagar, they showed exactly how things are done, and the simplicity of the Phakic IOL comes forth. So thank you very much. But the biggest thanks is, of course, to our sponsors, who Star Surgical, who have come up and sponsored this webinar. Thanks to them, and of course thanks to the scientific committee team who have really worked and who have really put the show across. Thank you very much, and a good night to every one of you.
Thank you, Partha. Thank you.